Ladies and gentlemen, the Maryland Healthcare Commission meeting will now come to order. Before we begin, the world knows, reported by the New York Times and the Washington Post, that I am actually serving in this capacity for the last time as a member of the commission. And I want to say to you, I don't believe in long farewell speeches, but I want to say a couple of things about the commission, about the staff, about the state of Maryland. I've served on the commission now for 8 years and served as chairman, had the honor of being appointed by Governor Hogan as chairman of this commission. And those 8 years have been a remarkable personal and professional experience and a great pleasure for me personally. During the course of that time, and especially recently, I've had an opportunity to get to know many of the commissioners, the people who have served on this commission, giving of their time, their effort, their energy, deploying their knowledge and skills and abilities on behalf of the state of Maryland as commissioners, serving as commissioners, and anyone who's done this knows what is required. It's a job, in effect. It's a second job that requires a great deal of effort. With regard to the staff, I have said it publicly before. I'll say it again. It's not the last time I'm going to say it, but I think that the staff of this commission is a model of professional civil service. Administrations come and go. A Democratic administration will be elected, and then a Republican administration will be elected. The laws and the rules and the regulations that have to be carried out are pretty much the same, but there's a change in policy or a shift in priorities. The one thing about being a civil servant is that one has to serve impartially those who represent the people. And I must say that in my experience, the service, the dedication, the professionalism, the impartiality has been outstanding. There's a word for that. It's a very old and noble word. It's called patriotism. And I think that the people of Maryland have been very well served. I also want to say that it's been a long road in many respects. We've been through a lot. This commission has its ups and downs. But I do feel very strongly about the fact that we have a very strong commission now, and that we have done our duty. I feel that after 8 years, it's time. I want you to all know that I'm leaving with a great positive spirit, and I feel very, very strongly about the future of the commission. I'm very, very proud of my association. So thank you very much. Yes, you can. You're allowed to talk. The First Amendment thing.
Yeah. I think one of the things you'll be most grateful of when you leave here is that you won't have to listen to me talk anymore. I just want to personally thank you for your service on the commission and for the opportunity to work alongside you for all of those 8 years in 2 different administrations. Your focus on quality and value in healthcare for the citizens of Maryland has been admirable and has been a model for the rest of us. Your experience in that area has been absolutely invaluable. I think there are some other things that you have focused on during your time here that has been extremely valuable. So it's your focus on creating transparency for the consumers and insisting that we continue to look in that direction. It's also notable that you have taken on the most difficult role of commissioner during our time here. I think the PG certificate of need was probably the most difficult one that I've seen in my time here, and you handled that in a way that was absolutely masterful and a model for the rest of us. And your leadership and your leadership style that includes careful and open listening to everybody's point of view, even when they are clearly in disagreement with some of the points of view that maybe you and I might share at times. you actually listened and made people feel included, and they were included in a way that was really masterful. So thank you for all you've done. We will miss you, and we are grateful for the contributions you made.
Mr. Chairman, so on behalf of the staff, I want to say, and not only speaking for me, but for the entire staff, how much we appreciate your service to the commission. I was touched with what you said about the professionalism of the staff. It has been the senior staff's goal to serve the appointed members of the commission without regard to personal opinion, to put those aside and to listen to the commissioner's perspective and to implement your wishes. And I think we have striven to do that, and I think hearing it from you is really important today. I want to talk kind of about three of the values that I really saw in your leadership that have been very important. The first is your honesty and integrity. When I approached you to do the Prince George's review, I think we both worried how that was going to come out. It has been a struggle for more than 20 years, and Commissioner Bob Moffett from the Heritage Foundation brought a solution that people could all agree with and could conclude that was fair to both the residents of Prince George's County and the residents of Maryland moving forward. Your commitment and passion was really on display throughout the past 4 years, but we could see it most dramatically when you talked about transparency in price and quality. It's something that I knew you believed in, and you put down a pathway for us to move forward along that manner with some clear directions, but also some appreciations that we have to be respectful of providers who are delivering care on a daily basis and may not be able to control all the factors of that influence quality and safety. And lastly, your ability to be innovative and resilient in the face of challenges, and we've seen that even today as we consider some of our CON modernization activities, that you've been willing to take on challenges, to work with both the industry and residents of the state to make services more plentifully available, more accessible, and I think ultimately we're going to see that improvement reflected in the health system that we have here in Maryland. We wish you the best of luck, but we also want to say, as we part company today, that we hope to gosh that we haven't seen the last of Bob Moffett going forward. Your occasional irreverence was your occasional better than that. It was really took the edge off of a lot of tense situations. The fact that you were willing to say, we, in the whole scheme of things, are doing important work, but we ourselves are not so important that we can't laugh at ourselves occasionally. Thank you.
All right, I think we ought to get to work. What do you think? Okay. Ladies and gentlemen of the commission, you have in your packets copies of the minutes from 3 sets of commission meetings, which include the January commission meeting and 2 commission meetings regarding legislation that took place by a conference call. each set of these minutes will require a separate motion and a vote. I would like to note that on the January 17th, 2019 public meeting of the commission, Commissioner O'Connor was in fact present, and so the final version of these minutes will reflect that. But anyway, with regard to the January 17th public meeting, do I have a motion to approve those minutes? I have a motion and a second. Okay, any further discussion? All in favor? Any opposed? Okay, the second issue is the January 25th public meeting of the commission regarding legislation that took place by teleconference. Do I have a motion to approve the January 25th minutes? Motion. Second. All in favor? Any opposed? And finally, a motion to approve the minutes of February 15th, a public meeting of the commission regarding legislation, once again, that took place by teleconference. Do I have a motion to approve the February 15th minutes? Motion. I have a second? Second. Okay. All in favor? Any opposed? Okay, thank you very much. Commissioners, as always, you have received written updates from our centers. You've all had a chance to read the written updates and digest the information provided to you. Do any of you have any questions at all on the written updates for the center directors? Does anybody have any questions at all from your written update? Okay, fine. Does the executive director have any additional updates?
Thank you, Mr. Chairman. I have a very brief update, and it comes from a meeting we had with a legislator last week that pointed out that for consumers, their ability to identify information on our CON proceedings is sometimes very difficult. I believe that providers, hospitals, nursing homes, organizations that have business before the commission know where to get that information, but we need to think a little harder about making sure information pertaining to CON, Certificate of Need, applications are more readily available. Although we are planning to do a more exhaustive re-engineering of the website over the next 6 to 9 months, we are going to be looking at ways in which we can make information on CON available on our public website more quickly. It didn't really occur to me personally that it was hard to find, but then I spend a couple minutes a day at least looking at what's out there. But I think that we have an obligation as we consider these very important projects in local communities to make certain that not only the providers but also residents are aware of what's happening. So we're going to be trying to make a change to provide some information on that. I wanted to say that publicly is more than anything else, that we certainly, it's not our intent to hide any of this information, and it tends to be complex, but that's no reason that it can't be made more visible.
Okay, that's an excellent suggestion. Commissioners, before we consider any of the action items today, just a gentle reminder that if you feel that you may have a conflict of interest, you feel that you might have an appearance of a conflict of interest, you have to, or you should, recuse yourself on an agenda item, and you should remove yourself to the conference room right next door. And after the deliberation on the subject matter at hand, then the staff will let you know, and you can come back and rejoin the commission to continue your responsibilities here. But just again, once again, if you ever feel that you have an issue, it's better to be safe than sorry, or have anybody complain about you voting or acting in your own behalf. Okay? All right. The next item is a certificate of need for Hope House treatment centers. Hope House is a representative. It's a subsidiary of Addiction Recovery Incorporated. It's a private nonprofit provider of non-hospital inpatient drug and alcohol withdrawal services. They also do counseling and residential treatment. Hope House has two locations, one in Anne Arundel County and one in Prince George's County. Hope House is seeking an approval of an application for a certificate of need to convert the existing residential treatment beds located in Laurel, Maryland, to a medically monitored intensive patient program and add space and establish a 22-bed intermediate care facility. Kevin McDonald, Kevin, you're here. Please present the staff recommendation. Thank you very much, sir. Good afternoon, Kevin.
Thank you, Mr. Chairman. Good afternoon, Commissioners. Addiction Recovery Incorporated, known as doing business as Hope House, has been in that business for, since 1983, providing services to adults struggling with alcoholism and drug addiction. Before I give you any details on the project, I'd like to maybe give you a brief background on these services, because I know there are a number of new commissioners since we last had one of these. The American Society for Addiction Medicine classifies treatment on a continuum from outpatient to medically managed inpatient. And we regulate only the 3.7 and 3.7 withdrawal management level. So even the residential services at the 3.5 level is not something that requires a CON. Also, Maryland categorizes providers as either Track 1 or Track 2. Track 1 is providers that provide their services to mostly insured or private pay individuals. And you will probably recall we had about a year ago several applications from Recovery Centers of America that Commissioner Sargent reviewed. And that was a Track 1. This is the first Track 2 we've seen in a long time. Track 2 serves at least 50% publicly funded patients. And in the case of Hope House, for the last 4 years, 83% of their patients have been Medicaid or indigent. They are currently operating a facility in Crownsville, a 49-bed inpatient facility. It has the flexibility to offer residential treatment as well as the 3.7 and above in all 49 of those beds. In Laurel, they operate in two adjacent facilities on Main Street. One is licensed for 20 beds, and again, it can flex between any level of residential services, including the 3.7 level. The adjacent building, the one that is seeking the CON today, has 18 residential treatment beds below the 3.7 level. And this application would request that those beds be converted to 3.7 and 3.7 withdrawal management, and that they also add 4 beds for a total of 22. And as we look at it, this would be the establishment of an intermediate care facility. Even though the facility is already there, they're operating 18 beds, they are below the level of which we regulate. So this is essentially the establishment of such a facility. In terms of need for the project, in its initial application, Hope House cited a large waiting list, the heroin epidemic, and the fact that the governor had declared the opioid crisis a state of emergency. We needed more tangible however, and in their replacement application, they gave us waiting list information for the first 6 months of 2018, and that waiting list grew from 120 in January of 2018 to 172 by June, averaging 146 persons for that period. And the way that's calculated was, I believe, every Friday they looked at that waiting list and came in with a monthly average for what that waiting list is. So a pretty significant waiting list. In addressing alternatives, there are no other treatment facilities in Prince George's County with 3.7 level services, either track 1 or track 2. The alternative treatment approach of offering detoxification treatment in a local hospital would be significantly more expensive and doesn't offer the same continuity of care that this provider would be able to bring to the table. And as I mentioned earlier, the only other certificates of need that the commission has seen probably at least in a decade has been for track 1 ICS that do not participate in the Medicaid program. Looking at the viability and financial feasibility, there's no cost to implement this project. The space exists. It's really just a conversion of the level of care that would be permissible in the service, and the addition of 4 beds. And the space is already there to do that. Hope House has shown a positive margin in the past, and the incremental impact of this proposed project would enhance their viability. It's more revenue, more reimbursement at that level. Of course, there's more expense with the staff that would be required as well, but the additional revenue outweighs the marginal cost of staff. So the project would enhance the organization's ongoing viability. Looking at the impact, increasing the supply of this potentially life-saving service and offering a lower cost alternative to treatment in hospitals seems like an impact that can only be seen as positive. Therefore, the staff recommendation is to approve the project based on the staff's conclusion that the proposed project complies with the applicable state health plan standards, and that the applicant has demonstrated need for the project, its cost effectiveness, its viability, and that the impact of the project is positive, primarily because it will improve access to intensive medically managed inpatient alcohol and drug treatment services, and that these services will primarily be available to low-income households who currently are underserved with respect to this level of care.
Thank you very much, Kevin. The issue then before the commission is the approval of a certificate of need application for Hope House. Do I have a motion? I have a second? Okay, fine. Is there any discussion or any questions for Kevin? Yes, Dr. O'Connor.
Just one question, Kevin. I just wonder, with the backlog of patients waiting for the service, can they add any more beds?
As of the time I came up here, I don't believe there was anyone representing the applicant. There is.
Oh, okay, please.
Okay. Yeah. Peter D'Souza is the CEO.
Welcome, Peter.
And
thank you very much for coming.
That's the question. I'm not sure if they have the space, but I'm sure
Peter, can you answer the
D'Souza
question?
can answer that.
Yeah.
The question is whether, given the backlog of services, the long waiting list, whether there is the possibility that you could expand even further.
Yes, actually, we have 2 facilities in Laurel and 1 in Crownsville. And actually, I'm looking at Crownsville to put up a 24 hours, 7 days a week crisis emergency center for 20 beds. So we're trying to expand our capacity. A lot of people overdose on the weekends and in the evenings when none of the facilities are open. So I would like to open one that's 24 hours, 7 days a week for that.
Are there any further questions? Any further discussion? Okay. We have a motion. All those in favor of granting the application, say aye. Any opposed? None. Very good. Mr. D'Souza, you have your con application.
Thank you very much.
You're welcome. Okay, the next item, Kevin, is the next item is another application. It's an approval of a certificate of need for Anne Arundel Medical Center. At our April 2018 meeting, the commission adopted a decision by Commissioner Tamarchio and awarded a CON application to the Anne Arundel Medical Center to establish a 16-bed special psychiatric unit for adults at the hospital, or hospital for adults. The Anne Arundel Medical Center seeks approval of a project change to increase the cost of the project. Mr. McDonald will present the staff recommendation on this. Kevin?
Okay, thank you. I know the commission has seen a number of these in recent months. As you know, there are certain changes to a project that require action by the commission, and the reason we're here is that it is a cost increase that exceeds the inflationary allowance that is defined in regulation. As the chairman mentioned, this is a 16-bed freestanding psychiatric hospital to be built about 2 miles from the hospital campus. It was approved in April of 2018 after a lengthy review process that was extended by revisions to the project and changing cost estimates, as well as by the intervention of an interested party. This change would add $3.3 million to the cost of the project, which is about 13%. And that increase is attributed to a couple of factors. One is that the cost estimate, because of the delay in the action, the cost estimate was about 20 months old when the project was approved. And in that time, in their intervening time, there were significant increases in material costs due to natural disasters, Hurricanes Irma and Harvey, creating demand for those building materials, as well as government policy on trade agreements and tariffs, which also boosted costs of materials needed for the project. The additional capital costs will be funded with cash, so the amount of debt to be incurred on this project and related interest expense will not change as a result. Staff has reviewed the request for a project change in the context of the commissioner's conclusion in April of 2018 and concludes that the proposed project change would not have a material effect on the findings made by the commission at that time, and thus staff recommends approval.
Thank you very much, Mr. McDonald. Okay, so the issue before the commission is the approval of a change in the April 2018 certificate of need for Anne Arundel Medical Center. Do I have a motion? A motion, have a second. Is there any further discussion? Are there any questions for Mr. McDonald?
And I should say, we do have representatives here from Anne Arundel. Kathy Yerkin, the Vice President of Finance, Josh Jacobs, the Vice President for Strategic Planning, Paula Weiderlight, the Chief Strategy Officer, Luke Klott, the Director of Capital Projects, and Marta Harding, their counsel.
Thank you. Welcome all. Thank you very much. Anyway, getting back to the question at hand, are there any questions, any further questions for Commissioner? Yes. Commissioner O'Grady.
Get my microphone on. I'd just like to go through the costs and the cost estimate here. So the first reason is the delay, 20 months, and as you said, revision. So that sounds like some of the blame there is us and some of the blame there is them in terms of that going back and forth. But at the same time, you also said that there's provisions in here that take into account inflation over time. So if there's a 20-month delay, does not the inflation provisions sort of take that into account?
I think it does. The inflation provision, the allowance would be somewhere over 900,000.
Okay.
And this was a 3.3 million.
3.3 million. And then I guess it's just in terms of thinking about these hurricanes. Harvey was 2017. I mean, certainly we know that there's a short-term bump in terms of, but mostly kind of tradesmen and things like that. I'm not quite sure how, when the staff did their analysis kind of decomposing, how did this go to 3.3? What kind of an effect are we talking about from a hurricane 2 years ago?
I think I would let the applicant answer that.
Okay.
Yes.
Commissioner O'Grady, Marta Harding on behalf of the applicant. I think I have Mr. Klopp with me, who is the director of facilities for Anne Arundel Medical Center. I think he can speak to. I think it has to do with the timing of when we entered into the contract, and at that point in time was when we were experiencing kind of these immediate impacts of the hurricane.
That's right. Yeah. So we were designing at the time that this was occurring. As you know, when a hurricane or something like that occurs, downstream effects can take several years. The impact on mechanical equipment, roofing, those kind of materials that the rebuilding buildings would need. So we're seeing increases in production times, material costs, steel estimation, those kind of things.
Okay. And in terms of thinking about it, is it mostly labor or is it mostly the material? Because labor tends to be local, materials tend to be national. So
primarily materials. Labor kind of stays flat.
Okay. So unexpected. Do you want to, in terms of, because the third one there about something about U.S. trade policies, I just didn't understand what that was. Did steel go up? Is this President Trump and embargo or tariffs and whatnot?
Yeah, some of our materials come from out of the country, from furniture, things from China. We have lots of being made and produced in Canada. So some of those.
We're not picking on our Canadian neighbors, are we? I thought that was pretty okay.
But is he buying American steel? That's the real question.
Can he find American steel is another question.
The things like manufactured somewhere else that we did see an increase in steel prices of $200 a ton. We did try to pre-buy things as we realized it was happening.
Okay.
So we did try to get ahead as much as possible.
Okay. Thank you.
Very good. Any further questions? Any further questions at all? Okay, we have a motion. We have a second. Any further discussion? All right, very good. Before the commission, then, the motion is an approval of change in the certificate of need granted April 2018 to Anne Arundel Medical Center. All those in favor, please say aye. Aye. Are there any opposed? Okay, very good. Well, you have your certificate of need. You're welcome. Thank you. Very, very good. Okay, item 5 has to do with the state health plan for facilities and services. This is the comprehensive care facility chapter, the proposed permanent regulations. At our October meeting, we adopted COMAR 102420 as proposed permanent regulations. Following our action, these regulations were posted in the Maryland Register for a comment period. Linda Cole will present the recommendations today based on an analysis of those comments. Some of the recommended changes are deemed to be substantive, and because they're substantive, that would require another set of proposed permanent regulations and another formal comment period. Everybody should understand that. If this goes forward, the commission will then vote to withdraw the COMAR 10-24-20 as adopted back in October 2018. And after that, the commission would have to vote to adopt revised proposed permanent regulations that replace the language as recommended. So, Linda, the floor is yours. Would you present the review of the comments and your recommendation to the commission?
Thank you, Mr. Chairman, Commissioners. What I would like to do today is to briefly review the process for developing these regulations, review the major comments, staff response and recommendations, and then discuss the next steps. In developing this chapter, we used an extensive process of public input that included 3 nursing home work group meetings, 3 meetings with a subgroup of commissioners, and an informal public comment period. We presented this chapter to you in October, where you adopted these as proposed permanent regulations. Following that action, a formal comment period was held, and we will be presenting these comments. We are now at the step shown in blue. It should be noted that at the October meeting, we requested action from you on both COMAR 10-24-20, the Comprehensive Care Facilities Services chapter, and COMAR 10-24-08, which is the remainder of the nursing home chapter that now deals with chronic hospital services. This presentation focuses on COMAR 10-24-20. Following commission action in October, the notice was published in the Maryland Register, and the formal comment period was held between December 7th, 2018 and January 7th, 2019. No comments were received on COMAR 10-24-08, but 21 individuals and organizations commented on COMAR 10-24-20. In addition to the nursing home associations, many nursing home administrators offered similar remarks. The major issues shown here will be discussed individually. The proposed chapter maintains the principle that generally a nursing home that proposes to increase bed capacity be located in a jurisdiction that has identified need for additional beds before its proposal may be accepted that is docketed for review. However, when adopting these regulations, the Commission recognized, as it has with other state health plan chapters, that there are certain kinds of population needs that can be met by certain types of projects. 3 specific docketing exceptions were included in this chapter. First, situations where more than 50% of the facilities in the jurisdiction are below 3 stars in the overall star rating. Second, replacement of facilities below 100 beds to make those facilities financially viable. And third, signed risk-sharing agreements between nursing homes and hospitals to address the total cost of care. So I'll go through each of these individually. The first docketing exception refers to situations where more than 50% of the jurisdiction's nursing homes had an overall star rating of less than 3 stars, which is below average, for a 2-year period. As shown in this table, at this time, only 3 jurisdictions, Allegheny, Queen Anne's, and Washington, would qualify. This docketing exception is designed to increase Marylanders' access to higher quality nursing homes in these jurisdictions. In the case of Queen Anne's County, there is only 1 nursing home that serves that jurisdiction. In response to previous comments during the informal public comment period, the Commission adopted staff's recommendation that these regulations look at star rating data for a 2-year period rather than 1 as originally proposed. This should take into account fluctuations in ratings. The industry states that this would potentially harm all providers in the jurisdiction, but it should be noted that facilities with a 4-star or 5-star rating could apply for additional beds under this provision. Staff notes that this rule did not generate many comments since it's intended to benefit existing small nursing homes that have older physical plans. This rule would permit the replacement of an outdated freestanding nursing home below 100 beds, provided that the applicant can demonstrate that the additional beds are needed to make the replacement facility financially feasible and viable. This rule would permit additional capacity for innovative projects to address the total cost of care under agreements between nursing homes and hospitals approved by HSCRC. This docketing exception generated the most comments. The commenters' major concern seems to be the impact of approving new nursing homes to work with hospitals and potentially shift post-acute admissions from current providers to new providers. Staff notes that this docketing exception requires the applicant to demonstrate that additional bed capacity is warranted to make the proposed arrangement work. This agreement must be reviewed and approved by HSCRC. There is also no prohibition from current nursing home providers developing agreements with hospitals to address the total cost of care. In fact, such arrangements could be done using existing beds and thus without a CON. However, in response to comments received, staff recommends that this third docketing exception be deleted. Its development was consistent with the CON Task Force directive to update chapters to address the total cost of care. However, the comments indicate that this is premature because HSCRC has not provided specific guidance on what types of projects would be acceptable, and further work needs to be done on the care redesign program. Staff recommends going forward with promulgation of this chapter, including the bed need forecast. The chapter can be amended later as needed to address total cost of care, and I'll be discussing the specific actions needed on this change at the end of the presentation. On further comments, waiver beds are 10 beds or 10%, whichever is left, which may be provided to nursing homes upon request under specific circumstances. The Commission has discretion in drafting regulations regarding the circumstances under which waiver beds were awarded. These are intended to provide some institutional flexibility to address an immediate issue and awarded without a CON or other Commission action. Under these regulations, as adopted in October, facilities would have 1 year to use the beds or lose them. These beds can be requested every 2 years, provided that the licensed capacity of the facility has not changed. The issue is that many of these beds languish for 10 or 20 years, resulting in a bed inventory that is inaccurate and that constrains the forecast of future projected bed needs. In its adoption of the proposed chapter, the Commission continued its longstanding policy that requires the successful nursing home applicant to commit to serving Medicaid patients at a specified level of patient days that is commensurate with the participation of other providers in the jurisdiction or region, whichever is lower. Commenters argue that this is no longer needed. However, the Commission has long held that this policy is an appropriate way to assure that Medicaid patients have reasonable and equitable access to the same complement of nursing home beds as other patients enjoy. It is consistent with the Commission's focus on the social determinants of health and equity of access. It is also notable that the 2017 Joint Chairman's Report on Medicaid indicates that this provision helps to safeguard access to nursing home care. The Facilities Guidelines Institute is a national body that develops guidelines to assist in the architectural design of various types of healthcare facilities. It is expected that these guidelines can be met in the development of new facilities. More flexibility is provided in the renovation of older facilities. In response to comments, staff proposes adding a non-substantive change to clarify that line drawings are acceptable. It should be noted that the Office of Healthcare Quality supports the Commission's use of the FGI guidelines and plans to incorporate them by reference in their own nursing home regulations. The CMS Nursing Home Compare quality ratings are nationally tested and validated measures. The use of the 5-star rating system, its pros and cons, was discussed in issue briefs at the Nursing Home Workgroup meeting and at previous Commission meetings. In response to comments made at the Nursing Home Workgroup, a provision was added that the owner had to have the facility for 3 or more years. Basically, the issue was that if there was a substandard facility and a new owner takes over, they need time to bring it up to a standard level. So this was suggested as the time period necessary for a new owner to bring a deficient facility up to a higher rating. There was also discussion of the Maryland Medicaid pay-for-performance system and why it is not the best measure to use. First, it is limited to Maryland and cannot be used to assess an out-of-state provider. It is focused primarily on long-stay patients when an increasing proportion of nursing home patients are short stay. And finally, it relies on the Commission's Family Experience of Care Survey, which has not been updated since 2016. There were a few comments also on the nursing home bed need methodology. The assumptions of the new methodology have been previously discussed, and I'm not going to go over them again, but basically the focus was to simplify it and to allow for more frequent updates of bed needs. I just want to note that since our nursing home bed need projections have historically been and continue to be conservative, the declines in nursing home occupancy in Maryland, shown by the blue line, have not been nearly as steep as those nationally shown by the red line. So we've been able to hold occupancy, though lower than historical levels of 90 and 95%. They've remained fairly stable as the national rates have declined. As we discussed previously, there's little to no bed need projected since the use rates in almost all age groups, but particularly the 85 and older shown on the right, have declined significantly and are using fewer patient days. This shows nursing home bed need updated with a 2016 base year and projected through 2021. I know it's impossible to read this, but although the shaded rows indicate positive need, they are eliminated due either to occupancy below 90% or the addition of a recent facility. So bottom line, there is no bed need projected. As we discussed, we are recommending that the third docketing exception be removed from the chapter. Since this is a substantive change, this would require that the Commission withdraw the recently adopted regulations and propose replacement regulations with the modifications indicated. This would require another formal comment period to address the modification. We would then return to the Commission for final action. So there are two separate actions, voting to withdraw and voting on replacement proposed permanent regulations. I'd be happy to answer any questions.
Thank you very, very much, Linda. Dr. Pollack, you had a comment.
Yeah, thank you. I want to thank the staff for a tremendous amount of work these past weeks or so in terms of working through this with the various constituents and addressing this. I think the staff recommendation is based on multiple conversations with the constituent groups, with me and with others individually. The constituent groups are very upset primarily about the total cost of care exemption, primarily because it was vague, and we tried suggesting additional wording, and they were still uncomfortable with it. And I think a lot of the discomfort in listening to them carefully and trying to listen to them is the issue of what exactly is it that we're specifically trying to facilitate, and what would it mean in any particular jurisdiction? And we can't answer that because we don't have such a project in front of us right now. In order for a project to come through, even under these regulations, it would require an agreement between a hospital and the HSCRC around such a risk-sharing agreement. And no such agreement exists right now, and no such agreement is in the foreseeable future. That means that if we fail to pass this, if we pull this out of the regs right now, it has no impact on anything. It can't have impact on anything until such time as an agreement between providers and the HSCRC is approved. When such a thing happens, we will have an opportunity to write additional regs in partnership with our sister commission, advising us on what's necessary to do it to create such bed need capacity were it to be deemed necessary. And at that point, we would have an argument that such additional capacity is or is not necessary in order to facilitate such a project that would decrease total cost of care for Medicare beneficiaries. And I think at that point we would have something more substantive to talk about. creating this level of discomfort around the reg, around the rest of the reg, over one provision in the reg, seems less advised. If we were to do that, we would risk potentially a legislative response to something like this. It's just not necessary when the rest of the regs really represent very good work that I think should go through. And that's the genesis of the of where we are right now in this process. The request is to withdraw the existing regs, strip out the total cost of care issue, and then resubmit. And that would give us time in the next 90-day period to address the additional comments that we have here, all of which I think are things that we can work through with the industry in partnership with the industry. Commissioner O'Grady.
Just a few questions. In terms of this, to a certain degree, we've got a simultaneity problem here, a little chicken and the egg here, about whether there's such a proposal or such a proposal might look like. The way I'm conceptualizing this working, though, so if I'm a hospital, I'm thinking about what it would take to develop one of these. Right now, if we pull this out, the way it currently stands, what we talked about in October, right now I can work out that arrangement with anyone I want to, as long as they meet other quality standards and those sorts of things. This, in effect, means I have to deal with the people who are already offering CCS in my local area. So I constrained if I'm hospital X, I've constrained the number of potential partners I can handle to only the existing pool, which leaves me very uncomfortable in terms of a kind of a restraint of competition. I can't work with the people I want to work with. I have to work from your list of people. Because right now, if they were comfortable dealing with the people who are currently there, there's nothing that restricts them from saying, no, I like those guys down the road at whatever. I'd like to go and do a deal with them. But we're now saying you have to deal with what we think of as in economics, the guild. The guys with the union card are the only people you can have on this job site. They're the only people you can go into with this arrangement. And I find that troubling. I find that troubling. Unless I'm somehow misinterpreting the implications of what this would mean. So if I'm let me finish that. If I'm that hospital and I'm not comfortable with anybody in my area that's going into something as scary as this sort of a risk thing and a total cost of care, I now don't ever put a proposal together. I don't ever come to our sister commission. It's a non-decision that we've had an effect on because we've tied their hands in terms of who they can actually partner with.
Yes. The issue is that we're not creating new people, we're not creating new capacity, we're not creating new anything. We're just creating a new pathway to potentially get a CON. Even if you say I don't like any of the current providers in the area right now, I want to partner with somebody else to do this. You'd need to get a CON to do it. Even if we had this in place, you'd need to get a CON. So somebody couldn't just come in and partner with Hopkins, for example, or
but correct me about how our docketing things. I mean, to a certain degree, the way this works is you couldn't even apply otherwise. And so I'm concerned about that kind of restraint of trade. However, that sort of notion of it. We're keeping outsiders out, whether they're qualified or not.
But your first step is you have to go to the HFCRC and get permission for this type of an arrangement to exist. At which point the HFCRC would come to us and say, we want this project to exist or we don't. And if the HFCRC comes to us, then we have an opportunity to respond. But this in and of itself doesn't create a CON. It doesn't get anybody. I can tell you
it creates
industry level.
It's got intended consequences or unintended consequences that greatly limit the ability of me, if I'm Hospital X, of me to put this deal together. I have to deal with with the guys with the union card. I'm part of a multi-state. We've worked in New Jersey with somebody else. I can't even consider those people because they're not here. Granted, if I wanted to consider them, I know they have to get a CON. But you're saying whether they could get a CON or not, they don't even get on the docket.
But even if they could get on the docket, then everybody in the local area who's got bed capacity can oppose. So the idea that somehow you're limiting that's a rate limiting hurdle from the standpoint of having worked with hospitals and doing this thing before, the need for the CON, that's a huge rate limiting hurdle. That's not, this doesn't seem to, you need the partnership with the HSCRC first, and then you need to get past the CON. And this is just sort of something that I think from this conversation, people will know that, and with the HSCRC conversation, they'll know that we're willing to open up that discussion at the point when we get close to that.
Okay, Commissioner Reimer, you have a question.
I have, I sort of agree with Commissioner O'Grady on this, because right now we keep talking about need, and there's no need, therefore there's going to be no more capacity, no more providers coming into these communities. Okay, so when you already say that, you're right. Everybody sort of steps back, puts a lot on the hospital to try and get the total cost of care model in place. Obviously, it's new. You know, I sort of understand a lot of what they need to do, but I think I like the language that's in there. It might be a little, we have some things in there, we talk about cost sharing and so on, which I think is a little premature on how that's really going to flesh out. But I like the concept to be able to give the hospital some flexibility to partner with somebody who's willing to do this. And the question of need, I think we're kind of in back in the old dark days of what need is, because I think need is changing. I mean, need is different now. The definition of need, I think we should look at that question, because we keep going back to, what traditionally nursing homes do. They need to be different. And I think they know that. There's a lot of money on the table here. There's a way we can take some of these costs out of the healthcare dollars that the hospitals are at risk for. Let's just come to the, we know that. So we have to be able to provide them with a way to move this fairly quickly. We can't just keep, dancing around this issue and figuring out what's, I know we're sort of being on the forefront a little bit. We're maybe a little early on this, but I'm kind of not willing to back off right now. I think we ought to just be a little more aggressive on this, saying, yeah, we need to look at this. It's a great concept. I think the nursing homes probably will step up. They should. There could be some financial resources available. These are patients that we're talking about getting out of the hospital fairly quickly. That if they're Medicare, there's some reimbursement available. Other payers will probably be able to step up, knowing that the cost will go down. So I think there's a lot of financial reward there. So we keep coming back to need. From what I'm hearing, there's no need. So as Commissioner already said, well, okay, so that means nobody can come in anyway. So I'm not willing to back off on this. I think this is a good thing in here. Whether or not there's too many issues discussed in that paragraph about cost sharing and so on, maybe we're a little bit, too early on that piece, but I think that concept should stay in there.
Thank you very much, Commissioner. Commissioner Sargent.
Thank you. I had the same concern, but I guess I had a question for Ben based on that. Is assume we pull this regulation, we don't want it to send a signal now that there's no point in discussing innovation, right? Because that's exactly what happens. Somebody talks to their legal counsel looks out and says you're going to have to get a certificate of need and the docket's not open. So those options are off the table. We're not even going to talk about them. Go some other way. What is our plan if we pull the regulation to make sure that discussion winds up with but the MHCC has said they will revisit this when there's a project on the table. So put those options back, Mr. Hospital, into what you're considering, and how involved will we be in that process of moving down towards the pike so that we can pull this regulation and deal with it when there's a specific instance. But I don't want to close the door now to that instance ever arising. Does that make sense?
Yeah. So I think what you're saying is, broadly speaking, I think everyone here agrees that regulatory commission should be setting incentives in place, setting directions. And I think the industry's reluctance to adopt this right at the moment is that the big opportunities that are being discussed are being suggested by our partners across the way, that these are 1.5 to 2 years away. So I think that the idea that there's something out there is sort of, we can't point to things that are out there yet. There are ideas, but nothing firm in place. The industry wants this to be thought of as in collaboration with the HSCRC efforts. In particular, they're most interested in initiatives in which a nursing home could be the convener. Currently, under the Maryland model, they are constrained by, they are reacting. Junior partners, if you will, to initiatives that hospitals launch, and to put this into sort of a level playing field, as it is in the rest of the country, before this is rolled out. Their argument is, let's get a full plate of a full menu of opportunities in which the industry itself can come forward with within the confines of the total cost of care model, can act as a convener themselves. We think we can be effective. We think we can be we can achieve with if the three key waivers that have been made available elsewhere, but are not yet available here in Maryland, which is the waiver of the 3-day rule, the requirement that a patient has to stay in a hospital 3 days before they're eligible for SNF care, the requirement that there can be no direct admit to a nursing home for skilled care, and 3, the waiver of the telehealth waiver, which is available through some of the initiatives available to nursing homes nationally. So I think there's a point there. I think that the most attractive models for taking on risk, they'd argue, are not available, and therefore, why not wait a little bit and better align with what's going to be introduced here in Maryland to work with what the commission proposes, which I think, like a lot of things, in spirit, there's probably strong support. In principle, where we have something unknown, there's a great deal of fear that some sort of very narrow arrangement can be established that would benefit only one facility, unbeknownst to everyone else in the industry, which I think I can take that both ways. Commissioner O'Grady, why do we care about that? But I also think that it does pose some challenges in the broader regulatory environment of Maryland, which is we have to look upon this as not just certificate of need, but very tightly regulated and what arguably is relatively low compensation on the Medicaid market. So I think in total, while I think it's important to send signals, we may be a little bit premature, and if we pull this back and began working with HSCRC in collaboration on some models that work, we'd get more momentum moving forward, both from outside the state and from within those players who I consider true innovators here. I am somewhat concerned, and this is my own personal judgment, that those that I would label as innovators have raised the most, some of the most significant objections to this. So I take it from that. The third and last point I'll make is that there's uncertainty if we go forward, that this might not provide some unbeknownst and unintended consequences for hospitals to restart transitional care units, which were popular about 2 decades ago, and that would seem potentially to be allowed under these models, under which a hospital would reestablish a transitional care unit owned by that facility, meeting our docketing exception. No one's willing to do this. I'll start my own, with significant negative impact to the industry overall. So I think when you weigh those together, each of those raises some concerns. I think we should, however, not shy away from the point that we move forward with HSCRC to set some directions on incentives that may be acceptable.
Commissioner O'Connor.
One issue that jumps out at me is the disparity in the utilization of beds in Maryland versus nationally. Those short-term beds, long-term beds, there are distinctions. But the slide you gave where Maryland's bed usage is sky high compared to nationally.
So they're all beds, all nursing home beds. It combines all short
So
short-term,
we
long-term.
concerned about what's driving that and what is driving the increased usage. Is it length of stay, hospital trying to decrease length of stay to get patients out earlier?
It actually, historically, going way back, nursing home occupancies were about 95%, or 90%. They've now gone down. The point was that by being very conservative in bed need, which we have been for many iterations of the chapter, we've been able to keep occupancy fairly stable while national occupancies have been going down because of alternative services.
Okay, so our close attention to bed usage has created that disparity.
Right.
Is there any conflict of interest with hospitals that develop rates with a nursing home?
There are collaborations going on currently. Several months ago, you voted to approve a project with Carroll Hospital that Carroll Hospital Center proposed, in which they acquired a nursing home. In your application, stated that they were planning to move that nursing home onto the campus of Carroll Hospital. So that is occurring and occur.
I also wondered if the risk of readmissions is driving increased utilization of nursing home beds, sending to a nursing home instead of running the risk of having them readmitted in 30 days. I'd like to know the length of stay of Maryland hospitals compared to nationally.
So I will be happy to share you a quick fact that rivets the eye after this. We've made progress, but lengths of stay are still a bit higher than the national average. Our use of hospital outpatient services for the Medicare population are a bit higher, but what's going to be challenging is the costs are significantly higher in both the outpatient and inpatient settings. So the hospitals have their work cut out for them, and certainly collaborations with nursing homes are one way to reduce the inpatient per capita costs, as well as to some extent outpatient ED.
Commissioner Pollack.
Yeah, a couple of points. I think you're spot on in noticing that difference between our 90% utilization rate for nursing home beds and substantially lower nationally. As Ben pointed out, the average length of stay for Medicare patients in Maryland is longer than it is in other states. And I think that's partially driven by the high utilization rate of nursing home beds. It's harder to find nursing home beds for patients when you need them in Maryland. That discussion about whether we should loosen that number, we should bring it down below 90%. That's separate from the total cost of care clause. It's important, and it's, I think, a lot more important than the total cost of care project clause. Right now, until the HSCRC approves any model, any potential model, there's nothing that this clause can potentially facilitate, because there's nothing that the HSCRC has said yet can go forward. And it's not that somebody's bringing it to it; it hasn't even laid out a list of options, right? So until we work with them to do that, this can't happen. Which is why this taking this clause out right now, and Ben, correct me if I'm wrong on that at any point, but
so we do have one, I would say, project that's working its way through the commission of a project that is specific that we will be bringing to, but that's not related to this clause. It's not related to the clause.
Of course, that length of stay, it's catch-22 that Medicare mandates a 3-day stay in the hospital before going to a nursing home. So
we need a waiver from that. That's one of the things that we need a waiver from.
Yeah, they're driving the length of stay up themselves.
Commissioner Metz, did you have a comment?
Of course, I'm in the industry, and I've worked on the task force, and I thought commission staff had worked pretty hard at developing a sort of compromise that I thought would fly with the industry, which didn't. Of course, politics is the art of compromise, or compromise is the art of politics. And right now, this, from all indications, this can't get through the legislature. So we could push it through and it'll get triangulated and killed anyway. So, best to try to meet somewhere in the middle. All the points are well taken. I understand what everybody's saying. I mean, I hear the industry talking about, and what Ben mentioned about reopening what was referred to as, you know, subacute beds at hospitals, which they got away from 10, 15 years ago. Industry's very scared about that. Andy makes great points where nothing's going to fly unless the folks down the block allow it to anyway. So, I mean, there's lots of good things in the regulation that we try to develop, and I think even the industry liked with, you know, ease of new construction with existing beds and ease of creeping beds, et cetera. But it seems like we're at a point, and I really thought it was a decent compromise, really. My facilities has a 98% occupancy. I mean, I'm not afraid of competition. I think you provide good care, people come to your facility. That's the bottom line. But at the end of the day, right now, the industry's powerful. And not just because they're worried about dollars, they worry about care too. They really do. Where my facility, full disclosure, is a member of Lifespan's organization, and I know those folks. And they didn't really hide the fact that they would seek legislative remedy as we were going through this, and it looks like they'll be successful with that. So almost would be an exercise in futility to move forward.
So you, just to be clear, you're in favor then of the staff recommendation to withdraw this and
I am, especially, you know,
try it again.
I think Dr. Pollock's wisdom on this is very good.
Commissioner Sargent.
I guess one last thought, and I'll vote for this, not happily, because it won't make any difference whether we enact this and it's reversed by the legislature or we enact it and nobody follows it. I'm hearing 1 to 2 years from now, we might come up with a plan to have something novel risk-sharing arrangement between the nursing home and the hospital or a new entrant. And maybe like 1 to 2 to 3 years after that, it'll have some effect on the cost of care. So maybe 5, 6 years from now, that'll factor into how we're doing under the waiver. So what? Like, that's Maryland's big initiative to keep the cost of care down, to preserve the waiver. You know, I feel that our pace as a state might be a little too stately.
One thing I should mention, not to interrupt, going back to Jerry's comments, there are some teeth entering the industry as far as readmission to hospitals now from long-term care, beginning with the new changes in Medicare. We will now be dinged. They're now watching our readmissions to hospitals. So that's you know, it's been that way for the hospitals for a while. That's the invention of observation units, et cetera. Now we're going to see, you know, they're on the long-term care side to try to dial down and prevent unnecessary readmissions to the hospital. Not only the cost is a big part of it, obviously, but there's trauma to residents with that transfer as well. Especially if you have the technology in place within the nursing facility to prevent that and take all the steps that you need to take for an unnecessary readmission. So that part of it has just entered the playing field. They started to gather the data about 18 months ago, and it's now being implemented. So I just wanted to clarify that.
Yes, Commissioner O'Grady.
Just to sort of wrap up, as I think you can probably tell, I'm not in support of the staff recommendation to pull this provision. I understand that other powers may intercede, and that sort of, but I do believe that Maryland has not maybe fully grasped yet what total cost of care is going to mean, and to start taking tools out of the toolboxes of the hospitals that are going to have to do this and limit who they can work with and who they can't, even if there isn't a viable proposal for years. I don't want Randy's chilling effect that they think I have to only deal with a set number of people. So I do think that this is the kind of stuff that if something is going to kill total cost of care in the state of Maryland, it is going to be little skirmish by little skirmish like this that does it. And so if someone else wants to be on the record as throwing barriers in the way of it, I mean, nobody likes to be overridden by a legislative action. Nobody likes that. But at the same time, I'm not willing to kind of support something I think is as problematic as I believe this is. And if they want to do the wrong thing, that's their business. But I'm not going to do the wrong thing.
Well said,
Yeah.
Mr. O'Grady. I would just simply say that this is the kind of quality of discussion that we should always have on matters like this. We're having a full discussion. And please, when the vote comes, everybody is to vote their conscience on this and what they think is best for the state.
The only thing
Commissioner
I wanna
Reimer.
make, when I look at the original proposal we had that we approved, it says here that it has to be approved by the HSCRC. That's the first thing, bullet point. So, I mean, I think taking this out, if we leave it in, if it's not approved by the HSCRC, it's not going to happen. So, the fact that there's nothing, in the pipeline, we not see it right away, okay, then we don't have to worry about it. When something gets approved by the HSC, at least we're ready to do it, as opposed to having to come back and redo amend this legislation. And my concern is coming back, and we know how it is, and asking for a change, okay? So it says in here that HSCRC has to approve it. So if there's nothing there, then this won't be maybe implemented right now in the next few months, but maybe a year from now, there's several projects on the table because these hospitals are having to do these things. And I guarantee you there are some things on the chopping list that are on their desk right now that we haven't seen yet, will be coming soon. I would hate to have to sit here and then 3 months from now we're having to bring this back up because all of a sudden we're scurrying and have to go back and get several months of feedback. So that's my feeling. I don't think it's something that I would support taking out. I'd like to see that stay in there.
Okay. Any further? Commissioner Wang.
I was struck by what Commissioner Metz very wisely said, that politics is the art of compromise. And if we go against the staff recommendation, we'll be overridden by the special interest groups, by the legislature. And I just, as a relatively new member, I just want to ask, is that our job then to simply defer always to what we think the legislature wants us to do? Or do we ever come to a point where we say, well, even though we might be overridden, even though there are many folks who are against this, we should vote our conscience and vote for what we believe is the correct course of action.
Commissioner Pollak.
Yeah, I think I hear what you're saying on that. I just think that we've got one item in the regs that's not going to make any difference tomorrow. And it's not going to make any difference. And the point when it can, we can act and we can do it in an emergency fashion really quickly if we need to. But the likelihood that it's going to do that anytime in the near future in the next year or two is slim. Yet we put the rest of the regs at risk when we do that. We've got a lot that's in here that's very good that we should continue to move forward on. And I think that with more conversation around this one, we'll get this one too. But I think we have to have more open conversation around it, and we have to be very clear that the goal of this is not to dig in progressively into the CON, which is a core element of the market that has developed here in Maryland. Like it or not, it's there. I don't like it, but I didn't get to start it. It's already there, and it is what the market is. And if we're sending the wrong message to the market right now, we're going to scare them in ways that we don't need to, and we need their cooperation in other areas. This is that art of compromise. This is figuring out that this one issue is not that big right now because it doesn't have any effect in either direction. I agree wholeheartedly with the comment about it has to be an HSCRC approved project. So who cares? There's not one there. The first thing I looked at, who cares? There's a who cares on both sides. But if we want 90% of these regs to go through, we just need to step back for a second on the 10% and come back to it. I'm not saying we abandon this concept at all. I say we abandon it in this version of the regs and then take it up again right away and see how we can work with the HSCRC to better define this in a way. Yeah, be strategic and better define this in a way that gets to where we need it to get. I don't have any disagreement with anything they said about where we should be going. This is all about how to get there.
You've just heard Dr. Pollak channel Edmund Burke. For those of you who are familiar with political theory. Any further questions? Go ahead, Commissioner Sargent.
I guess it's just a brief observation on the bigger problem. Is there anything this commission could be doing to move these sorts of projects along? Because I feel like we're having conversations we should have had 2 or 3 years ago at this point in the waiver process. You can see from my last comments, I'm concerned that it won't work because we haven't given ourselves enough runway and time. So that's not this discussion, it's for Ben. What can we be doing? And this was an effort to do something to move those things along.
Commissioner Metz?
I'm a political junkie. Okay. I've served in elected positions. That's probably a bad thing. Don't think lesser of me. But Commissioner Pollack is correct. I mean, the best deals are developed when everybody's a little bit unhappy. Okay. We like what we developed, what we initially developed, and there was some dissent among us, but we went forward, correct? So we got a little bit of pushback. Staff and Ben developed what I thought was a pretty decent compromise, and still even got more pushback. But as Andy says, we can get a lot of what we want now, and not all of what we want now. And if we can get the other side, I say the other side, but the industry and the politicians to move in the right direction, maybe we can do something positive. That's missing in our country right now, and that's why we can't get anything done, because it's impossible for people to meet in the middle now. They refuse to do that. Ideology is trumping realism. So right now I'm just trying to be a little bit real, understand where we are in this. What Chairman Moffitt said when we began the meeting about being unbiased and true to form. I'm sitting here as an owner of a facility and within the industry, and trying to be as unbiased and professional as I can in all of this. Trust me, I took a lot of heat for even stepping over into wanting to change this at all. I see what we need to do as far as saving costs, and because it's important, because we're bankrupting the nation over it, and the state, et cetera. So but if we can meet and get a lot of what we want now, and the industry agree with a lot of what we want now, then I think it's a good compromise.
Jason, Commissioner McCarthy.
Yeah, I think it's just a quick question on process, just to understand, when it comes time to vote. So right now we would vote, we would withdraw it, this particular piece would be redacted.
Right.
Then there's another formal comment period. So how long is the comment period before coming back for action, before going to the legislature? And what I'm trying to wrap my head around is it the same time period to redo this work if you take the risk now and send it as is, vote today, versus withdraw, comment period, redo it, send it again for approval? If it's all going to take 4, 5, 6 months to get the same relative outcome, is it worth the risk or the shot to take it now if we believe that this should stay? So I made a statement when I was really asking a question about the process, and maybe somebody just educate me on the process of how long it would take to redo this work versus submitting today.
Okay, if we withdraw and then have a reproposed, and we have language that you have in your packet for a replacement regulation, that can be voted on today as a proposed permanent regulation. We're then required to go through a 30-day comment period. And then between the time periods that AELR needs, the governor's office, and others, it takes, the earliest we would come back for a final action is May for this regulation. Mm-hmm. And we're trying to get this settled now so we don't have to have, every time you make a substantive change, you need to start the process again. So we would hopefully get it.
And that is a fairly quick.
Right.
This is doable. I think that's the point.
So the regs
No.
would be independent of the legislative session. That it operates on its own cycle. The most important thing is there's a 30-day comment period after they're published in the Maryland Register, and that's where these comments were generated during that 30-day comment period. So unlike the federal government, which has a national proposed rulemaking, you get comments and you go immediately to final regs. If we have to make substantive changes in these proposed regs, we go back to square one. So removing the docketing provision, we think would allow us to reach the point in May where we would bring these back to you to vote on for final regs. If we leave the third docketing rule in a variety of forms, I think as Commissioner Metz mentioned, we would promulgate them today, but we would then spend the next 6 weeks fighting in the legislature, and likely the outcome is unclear, but we likely would be coming back to you again in April saying we want to do what we have to do now. So it is somewhat of an assessment of what our chances are currently, given an environment where the industry is very agitated. There's a host of issues that are viewed as unfavorable to the industry right now, including proposals on minimum wage. So there's many people that are active and engaged in work with the legislature, and these regs are not necessarily the first thing that's ticked off to delegates and senators, but it's one of the things that's being ticked off as a source of unfairness that's occurring. And that's why I think we should. I actually am very sympathetic to what Commissioner O'Grady says. I just don't know how to get what you want today, and I also have a limited amount of staff to work these issues. We certainly, if it's the judgment of the commission to do this, we will put full force of staff to try to get this to happen. But it's also, we have to be realistic that we might be back here in April talking about the same issue.
Commissioner, wait a minute. Commissioner, yes.
Yeah, I mean, I've been sitting here agreeing with both sides. That's my problem. I do agree with Commissioner O'Grady and Kleiner, but on the other hand, the art of possible. Could we have some? Is there any way to have some at least sense of the commission in the minute that we are taking this out, but it is our intent over the next year, whatever period of time, that for the total cost of care to achieve, this has to be reintroduced?
Yes, I think we can say that. Sure, there's no problem. In fact, you have already said it, and so therefore it is recorded that this, in fact, is the sentiment of the commission. Now I'm going to ask everybody here, is it in fact true that that is the sentiment of the commission? Well, then that should be recorded in the minutes that the sentiment of the commission is as Commissioner Boyle stated. Yes, Commissioner Pollack.
So two things. One, I appreciate the sense of urgency around addressing the total cost of care issue. It's important to remember that we have a goal of $300 million. The gap between our growth in spending and the national growth, we're at 180 of that already in the first 5 years. So we're moving in the right direction. The thought that we're not making progress, that's just not true based on what we've actually done in the state. But I will personally commit to working closely with the HSCRC and Chairman Sabatini to figuring out how we get to innovation in these models. So we have real models and real something, not just words in regulation, but real models moving forward that have the potential to be successful in further reducing total cost of care. And we don't have to be terribly innovative to do this. Other states have done it already. we can just copy what's already worked in other places and make pull down a lot of low-hanging fruit. But yes, we have to commit to moving forward. We can't drop this. I agree completely.
Commissioner Sargent.
I just want to add, looking at what we are doing with the regulations, to me, the more important is putting a condition in that if your quality in the region is below average for the homes, that we're going to open it up so that someone can come in. I think that's probably a more practical impact, and I would not want to put that at risk, with a general legislative bill, because all kinds of things go into a general legislative bill. And just a comment on that, going forward, I'm not personally wedded to the STAR system itself, but I think it would be incumbent on an industry that doesn't like that to come up with at least as credible and at least as valuable a measurement that could be applied.
Excellent point. Are there any further questions? Any further comments? Any further points of debate? All right, hearing none. I would like a motion to adopt the staff recommendation to withdraw COMAR 10-2420, which was adopted as proposed permanent regulations in October 2018. Do I have a motion? I have a motion. Do I have a second? Second. I have a second. Okay. Is there any further discussion on this? Hearing none. All those in favor of the motion, say aye. Any opposed? 2. Okay. Commissioner O'Grady, Commissioner Reimer are opposed. All right. The Commission will now consider the adoption of COMAR 10-2420 as proposed permanent regulations of the Commission. This is without the docketing rule, okay? All right. Do I have a motion to approve? Commissioner McCarthy has a motion. Do I have a second? Commissioner Peters. Is there any further discussion on this proposal? Hearing none. All those in favor of the motion to adopt COMAR 10-2420, State Health Plan for Facilities and Services, Comprehensive Care Facility Services as proposed permanent regulations. All those in favor say aye. Aye. Any opposed? All right, Commissioner O'Grady and Commissioner Reimer are opposed. Thank you very much. This has been a full and honest and open discussion. Whether you won or lost on this, you have a right to be proud of your contribution. I want to say one more thing. The regulation of the industry is always a difficult matter because we are dealing in a political environment where there's a very, very profound special interest. And as we have said over and over and over again, members of this commission are not to represent special interests. They're to represent the best views as to what is good for the public. Nonetheless, having said that, we are going to do what we can to work effectively and positively with the industry in this case, with a view toward accomplishing as much as we possibly can to advance the modernization of the Certificate of Need process in the state of Maryland and do the very best we can to make sure that we have innovations that will benefit the residents of Maryland. I think Commissioner O'Grady's concerns, echoed by Commissioner Reimer, are valid. We have a very, very serious responsibility to do everything we can possibly do to break down barriers to competition and to improve the quality of care. So we're on our way on this. The staff is going to direct their attention. We're going to be open with the industry and do the very best we can to work with the industry to get a quick resolution of these issues. So in May, we'll have a final determination. Thank you very much for all of your, yes.
And also, I want to make clear from my earlier comments, I don't think that we're not making any progress on the cost of care. So I would personally think some of these programs need to have put in place sooner because of how long it takes and how hard it is to do. But there are a lot of folks working very hard on it, so it's not that we're no progress. I'm very concerned that there's not going to be enough at the end of the day.
Noted. That's a very good observation. Okay, the next item is a presentation. Johns Hopkins University Center for Population Health IT is going to present to us on the use of the medical database and the results that they've had under their 2-year pilot program. The commission established a data use agreement with Johns Hopkins University Center for Population Health IT in February 2017. Under the agreement, the commission required Johns Hopkins Group to submit quarterly reports on the status of the approved projects and report to the commission on the work at the conclusion of the agreement. Ms. Elise Lasser, Center Coordinator of Johns Hopkins Center for Population Health IT, is going to provide an overview of the research. And Dr. Uluwapo, is that correct? Uluwapo, I got it right. Faki? Very good, Faki. Dr. Faki, welcome. They'll present the research findings from the study completed under the agreement. At the conclusion of these presentations, we're going to have a few minutes for questions, and we'll consider the agenda, the next agenda item, which is to extend this agreement. Ms. Lasser and Dr. Piquet, begin, please.
Thank you very much for having us. We're excited to be able to present about our research and the work that's been going on. The chair has as the chair kindly has already kind of gone over some of the terms of the agreement, I will also provide a little bit of an overview of the project. Oh, sorry. And then present our current requests, and then my colleague here will present his research project that was done under this umbrella DUA. So as mentioned, the agreement started in February of 2017 and currently ends at the end of this month. The agreement gave the School of Public Health and Johns Hopkins University as a whole access to the all-payer claims database for the years of 2010 to 2014, which was released in February of 2017. Data for 2015 was released in September of 2017, and data for 2016 was released just this past September. And those release of the data was part of the umbrella DUA. And as mentioned, the process we've gone through is Hopkins faculty or students will submit an application to CFIT, and we'll review it along with some subject matter experts in the topics if needed to review and understand the feasibility and quality of the research being proposed. All projects are IRB approved through the Johns Hopkins IRB board, and then our staff sends the quarterly reports to MHCC on the current approved project. So overall, over the last 2 years, we had 8 applications submitted, full applications submitted. I've had about 9 or 10 other requests just trying to get a little bit more information around the data to see if their projects are feasible. We have 5 approved and active projects, 2 of which are PhD dissertations and 3 are faculty-led. From those 5 projects, there are 13 data users or analysts. 2 publications are currently in review, and then there are multiple publication and abstracts that are being planned to be submitted for both conferences and peer-reviewed journal articles once research is completed from these 5 projects. This is small, I apologize, but the 5 projects range from the use of claims and EMR to assess trends and correlates and quality measures for contraceptive care, evaluation of total patient revenue programs in rural Maryland hospitals, developing a geosocial analytic platform for risk prediction and visualization,
marginal and vulnerable populations within the patient-centered medical home, addressing gaps in literature with evidence from statewide multi-payer pilot schemes. And then contraceptive price elasticity in Maryland, estimating price effects on contraceptive use and unplanned pregnancy. The goals for Dr. Carolyn Moreau's project, use of claims and EMR to assess trends and correlates. I won't go through each of these aims word for word, but the basic overview of the project was to assess differences and characteristics in different kind of long-acting reproductive contraceptive measures. This work is finishing up. Dr. Moreau is unfortunately unable to be here to present, but she is willing to come and present her research and the findings at a later date if needed, if you would like to hear more. We do have 2 publications from this in review for published. I believe we were given the abstracts to those 2 publications. Dr. Brad Herring is evaluating the total patient revenue programs in the rural Maryland hospitals, and this is looking at total patient revenue and comparing the effects of some new policies that were implemented in 2011. And his sample was around the non-elderly adults that were continuously enrolled in employment-based insurance. He's particularly looking at inpatient hospitalization, including ED and not using ED, and hospitalized versus outpatient. It's a difference in difference study. They've done preliminary analyses, but with the addition of the 2016 data that we just received, there'd be more analyses, and the differences between the years would benefit. His research would benefit from having access to that data.
Can I ask a clarifying question?
Yes, I will try to answer.
Okay. Well, it just, and certainly Dr. Herring has, a very good reputation in this area. If you're going for continuously enrolled, the one thing that strikes me is that you would miss any deaths. And given that deaths are very expensive in this country, how did he adjust for that? Or?
Don't know,
Okay.
but I can ask him.
Okay. Continuous care, except death.
Yes.
Okay, good.
Dr. Hadi Karazi is interested in how claims data and adding publicly available geographic level and neighborhood information. So in this case, we're linking the American Community Survey, so census level data at the zip code level, to the database to see if there are predictors, neighborhood predictors for hospitalization and readmission. And then the one project I don't know a lot about, she just tried to start, she's one of our PhD students, contraceptive price elasticity in Maryland, estimating price effects. So this is more cost effectiveness study, looking at the contraceptive and prices between women aged 18 to 45 in Maryland. So our current request, because we just received the 2016 data and many of the research would benefit from having the newer data, given that there were a few policy changes in how insurance claims have been reported in 2014. We are requesting an extension of our current DUA for 1 more year. This would also allow our researchers who currently have access to continue with that access for publication. Most publications like to know that you have access to the data to change or update any analyses occurred. And if you have questions about the agreement or would like to get in touch with any of our faculty researchers or students who are doing the research, you are more than welcome to email me. And at the time, I'm going to turn this over to my colleague who's going to tell you about a specific research project done on this agreement.
I just have a question. I'm just curious, is extending the agreement, does that involve money, or is that?
So this model was developed with several academic institutions in mind, aimed at promoting the use of the medical care database, these large claim databases. So whereas we typically charge for these data we agreed that for a period, a 2-year period, we would make it available without charge. So it's not costing us anything, but sort of our cost of collection are also not captured in this, as it would be for other routine requests. Is that correct, Ken?
Yes, go ahead. Sorry.
I would like to say that one thing I liked very much about this, and I was sort of concerned when I saw it come up on the agenda until I saw what your projects were, is that often we see this sort of work and it's dissertations and tenure and not much helpful to policy. And you guys have not fallen into that trap at all. These seem quite well focused. This is not. I won't say any more. I think we get what I. So, but the one thing that I had a very ugly experience when I was at HHS at the federal level, where I sat in a meeting where the NIH guys talked about all this great work they had done about disability at the end of life, and the chief actuary of the Medicare program was at the table, and I said, so they shared all this with you, right? No. The guy who had to say whether the Medicare trust fund was going to go, insolvent in 2030 or 2031 had no idea that NIH had developed all this modeling to determine future disability rates and how quickly people would go out. So you certainly have picked great topics here in terms of trying to make sure that they're relevant to the debate. Is there any sort of a communications plan, anything that would talk about how you would actually, other than our, I come from that, we publish and we're done and ready to move on to the next thing. But that's just not effective with policymakers. Nobody, other than maybe health affairs, they're not really reading any of the standard peer-reviewed journal. So is there any plan to sort of, if it's rebuffed, it's rebuffed. But how do you get this sort of stuff in the hands of people who are actually going to make decisions?
I think that's an excellent question. I know in some cases, we work, so Dr. Hadi Farazi and I work very closely with Johns Hopkins Healthcare and Johns Hopkins Healthcare Solutions. So a lot of the work that's being developed with this project and other projects kind of get turned into how can we use it for the ACG model, so adjusted clinical groups, so that hospitals actually have access to some of these risk predictive models and can identify patients that are in poorly bad neighborhoods that affect readmission. So that's one way that we're actually turning into a practical use. Most of the researchers are from the Health Policy and Management Department, and they work closely with different policymakers. We will gladly share all the results and publications with you and further communications to make it more practical focused if needed.
Sort of outside my area, because we're not talking about the quality of the research. We're talking more the quality of the communications after the research is done, and then building that sort of dialogue. So that if you're dealing with people at the state health department who sort of, on the pregnancies one, and they're seeing a barrier to use, and it turns out it's a cost effect. It's got to do with a chilling effect of too high a patient out. They may come back to you then and say, well, that's great, and thank you. That helps answer some questions we didn't have. But can you tell us anything about, fill in the blank? So often I've seen this where you don't want to go in there thinking I'm here to educate the policymaker. It's a dialogue, and they're liable to, your next round of research is liable to be much more relevant because of your interaction with them. But I guess I would just hate to have this be, you've done good topics, and if you only use the traditional way of getting it out there in some general sense, it's, you've kind of covered half the journey, but there's still that other half to go. That would be my only recommendation. Think about how you would do that kind of outreach, how you would develop. If you think these are important questions, they were important enough for you to spend a year of your life in your professional working on it. It's not enough. And better informed, DCGs, or that's great, but that's not there yet. That's making sure people who do talk to policymakers have better tools. That's not you guys actually putting your research in front of policymakers. So, one point about Dr. Henry's work, I know that not only this particular one, Maryland, but basically with final model based on studies related to PCR
that's somewhat has been referenced by the folks in Pennsylvania who are associated with first what's called the Maryland model and applying it to the rural health safety moving forward, operating in this local budget. But I think those are good points.
Well, and also to your point that you brought, if this is effectively a subsidized data acquisition, then the notion of a public good and coming back into a public conversation is even more important.
Good afternoon, Commissioners. I'll just continue the presentation by talking about one of the studies that has been using this data. So like Elise introduced me, I'm a recent doctoral graduate of the program, and I actually will be starting at the Hilltop Institute in a couple of weeks. So part of that dissemination plan, Commissioner O'Grady, will be me working and trying to forge those linkages with our department, which is most academic, and the Hilltop Institute, which is very practical in terms of the work that they do. But the work I was using this data for is an evaluation of the Maryland Multi-Payer Medical Home Program, which was a program that was actually commissioned by the MHCC here in 2011. Under this program, about 52 primary care practices across the state of Maryland were supported technically and financially to function as medical homes. This was a program that involved Medicaid and also large commercial payers across the state. And I'm part of a larger research team led by Dr. Joe Marstella in our department. And we have a lot of studies evaluating this program, especially its impact on expenditure, access, and quality of care for marginal populations specifically, and vulnerable populations as well. The study I'm talking to you very briefly today is one where we use the MCDB data to look at what the impact of this multi-payer medical home program was for expenditure outcomes for the population served. One innovation compared to previous studies that have looked at this is that we try to focus on a population of patients using the MCDB data that consistently had very high levels of expenditure across the state. So whereas other studies had just looked at patients within specific practices, we focused on how this program performed on a statewide level, which we think is an innovation that is really worth discussing. So for the results I'll show you, I looked at how the probability of these patients being in this high cost category changed during the course of the program, and also specifically how their expenditure and utilization of services changed after the program began. So the main outcome is patients being in this category, which we defined as a consistently high cost beneficiary, which essentially is just a way of saying that they had very high medical expenditure, typically in the top 20% of patients over a 2-year period consecutively. So these are very medically complex patients with very serious diagnosis, and they typically account for a large part of health spending across the population. And I was looking at practices that took part in this multi-payer medical home program. If patients in these practices had a lower risk of being in this high cost category compared to comparative practices. So our use of the MCDB data was to find about 100 practices across the state of Maryland that were very similar to the participating practices with respect to structure, the kinds of providers in these practices, and the kinds of patients that visit these practices as well. So the analysis controlled for patient-level covariates, demographics, clinical characteristics, and utilization, as well as practice-level covariates like the size of the practice and the number of physicians in the practice. What we looked at basically was to see if the probability of being high cost changed over time in these participating practices. We also looked at for patients that were very expensive before the program started, what happened to them after the program began, so 2 years over the length of the program. And finally, looking at utilization outcomes among these expensive patients as well. So what you can see in this table is that we had about 116,000 patients from the medical care data, from the Maryland medical care database that we followed over time. And in each of the study groups that we saw, there was a small group of patients, about 5 to 7%, that consistently accounted for a big portion of healthcare expenditure in these practices. So these patients, although they were only about less than a tenth of each practice, typically formed about a third of the expenditure in the practice. And when we look at pharmaceutical expenditure, for example, on these patients, which are just about 5 to 7%, accounted for more than half of the pharmaceutical spending in these practices. So we thought this was a good population that practices would want to focus on, especially to reduce their total expenditure. On this table, just to summarize what you're seeing very briefly, we looked at what the risk of being high cost was after the program started. So here the estimates, if it's greater than 1, it indicates that the risk of being high cost increased during the length of the program. And if it's less than 1, the risk of being high cost decreased during the length of the program. And what we saw was that when we compared this Maryland program to the Care First PCMH program, which is another regional patient-centered medical home program, our program did not do as well. So the risk of being high cost still increased a little bit. And we think that's because the Care First program put a lot of emphasis on cost controls for their providers. So essentially, they redirected their providers and encouraged them to refer the patients to very low-cost providers because there was very heavy emphasis on cost control. But when we compare our program to the non-PCMH practices, we can see that there was definitely a reduction in terms of being high cost over the course of the program. So there was an expenditure effect for these beneficiaries. This second table shows how utilization changed over time. And what we can see here is that for emergency care visits as well as for inpatient visits, for these very high cost patients, we saw reductions in how they use these services, so which is a desired impact of the program. And specifically, we also saw an increase in the encounters between these high cost patients and their primary care providers. These high cost patients typically had fewer contacts with their primary care providers before the program started, and the program was associated with an increase in these contacts. So just to conclude very briefly, we're able to isolate a population of patients that's very small in the practice, but accounts for a big share of the expenditure. And when these patients were in the medical home setting, they were less likely to remain high cost over time at the statewide level. And also in this program, the reductions that we saw in expenditure were as desired. So there were reductions in inpatient admissions and also increased encounters with the primary care providers in these practices. So on that note, I'd just like to thank you very much. The data has been very, very invaluable to our projects, and we continue to do other studies that evaluate this program, and we really appreciate the extension for another year to complete this project. So thank you very much.
Thank you.
We still have to have the commission vote on that.
Right. Yeah. It's a democratic requirement. The majority has to agree. Are there any questions for our guests? Yes.
I'm just curious. When you're talking medical homes, I'm used to a population of very rare diseases that have very high expenditures, and generally they're not going to be well managed unless they're seeing specialists. So are these patients just seeing primary care providers and they have more prevalent disorders? Or?
Thank you for that question, Commissioner Ball. Yes, so these were general primary care practices. Some of them were very specialist in terms of the kinds of patients that they attracted. But what we saw was that the practices selected by the commission were more generalist primary care practices. So these patients were a small proportion of patients within each practice. Typically, a lot of medical homes are centered on particular diseases. We try to choose a population that is expensive and typically has more comorbid conditions, so multiple complex chronic conditions, and not just one practice, not just one condition as most practices tend to focus on.
Further questions? Any questions at all? None? Okay, well then, the action for the commission is to approve a 1-year extension of the Johns Hopkins Center for Population Health IT, a current umbrella data use agreement under the pilot program. So, do I have a motion to extend the agreement for 1 year? Commissioner Reimer, Commissioner Peters. Okay, very good. Is there any further discussion? Yes.
Very happy to support this motion. At the same time, we are giving a somewhat of an advantage to a certain subset of research organizations. And so I would like to suggest that this maybe be the, certainly not in terms of providing the data, but in terms of the subsidizing the cost of provision, is this maybe be the last year? I don't even want to make that a friendly amendment to the proposal, or just take that on staff for staff consideration.
So I think that's what Johns Hopkins School of Public Health has asked if we could extend, provide another year of data, and we've, after thinking about it, came to the same conclusion that you did, that we wanted to use this as a Kickstarter, but it couldn't continue on in perpetuity. We think there's value from the data. We believe it sort of got the pathway going, but if we're going to continue to do that, we would have to charge others more, which therefore didn't seem justified. So this is an extension on the use, but we're not agreeing to provide any more data. If they come back and say we need the 2017 data, it will be on a purchase arrangement as it would apply to everyone else. Is that correct, Ken? That's correct. So it's time, from a contract perspective, it's an extension of time, but not in extension of addition of any value. Yeah.
Any further questions? Well, okay, we have a motion. It's been seconded. So the issue is approving a one-year extension to the Johns Hopkins Center for Population Health IT for their umbrella data use agreement. All those in favor, say aye. Any opposed? Okay, the ayes have it. Well, you've got your extension. Thank you. Next item has to do with our legislative outlook. The legislative session is now picking up speed. A number of bills have been introduced, a number of them pertaining to the CON reform that will be considered over the next couple of weeks. Megan Renfrew, Director of Government Relations and Special Projects, is going to review the recent activities and describe the legislative activities that lay ahead and what our future will be like in Annapolis. So, Megan, tell us something that will make us happy. Please.
Here we go. Hello. So each week we've been gathering largely by conference call to review the bills that have hearings scheduled in that next week, for which staff recommends that the commission take some sort of position or action. And just as a reminder, and so this is in place of that call, which means we all get our Friday morning back tomorrow, which is exciting. So just as a reminder for all of us, our options for actions are to take no position, which is a good and legitimate decision, to submit a letter of information, or to express concern, support, or opposition. I wanted to provide you with, start first with an update on some of the things we discussed with one of the bills we discussed last week. So we discussed the bill that was going to require prescribers to submit information about financial incentives and gifts they got from pharmaceutical companies. That bill, the hearings for that bill were canceled. And that bill will be withdrawn. So I just wanted to give you an update that that is not moving forward. And so then I'm going to move on to bills for this week, for next week. So we have 3 bills we want to talk about today. So I'm going to start by talking about HB 607. So this bill seeks to add the State Primary Adult Resource Center to the list of entities that could receive funding from the Maryland Trauma Physician Services Fund for on-call and standby services. MHCC manages this fund. This bill further directs MHCC to develop guidelines for distributing funds to PARC, the Primary Adult Resource Center. So I have here that we were going to submit a letter of information. I had some further conversation with Ben this morning after these slides were completed. And Ben, do you want to go ahead, or do you want me to express where we're going?
So we've talked to the sponsor briefly. And we agree that when the fund was established, it was thought that the level ones would receive reimbursement through uncompensated care formulas. Those have largely disappeared. And other level 2s and level 3s, which are lower acuity facilities that treat patients with lower trauma acuities, would receive what's called on-call payments, that is stipends that a hospital pays for to a physician for being available to respond within 30 minutes, or standby, which is another type of stipend in which the hospital will pay a physician to be in the facility ready to respond. They were thought necessary to keep the trauma system going. After we think the request from Park, given that they are not eligible for either of those now, and given that the fund is now meeting all obligations, that it would be appropriate to do that. But then we carefully reviewed our recommendations over the past several years and felt as though we would want to offer an amendment, which would be to the bill, which would call for a study on all of the funding streams for the trauma system. The rule is that you can't offer an amendment unless you've taken a position of support for the bill. We think it's a good trade-off, as we'll be able to get some language in that would call for the MHCC, probably in collaboration with NIMS, to study the funding streams and report back to the legislature with perhaps a more permanent fix. We think a 2-year period is going to be needed, but we would support the intent of the legislation, which would be to provide some sustainability funding for a park going forward.
So do any commissioners have any feedback on that idea, so that we'd be moving forward with a support with amendment position?
Commissioner Pollack?
Great.
Commissioner Pollack is recusing himself in consideration of this matter. Okay. Yes, Commissioner Sargent.
So, looking at the language, the funding that's in the bill is maintaining trauma surgeon, orthopedic surgeons, neurosurgeons, and anesthesiologists, whereas the other funding streams are about just trauma surgeons. I don't know enough background to know why that would be different, or if that's anything I should be concerned about or to factor into my analysis.
So actually, yes. So our definition under the statute and regulations, those categories of surgeons are broadly defined as trauma surgeons. So
we don't think it makes any difference.
It's going to qualify the same group of physicians that are currently eligible, which includes trauma surgeons, orthopedic surgeons, anesthesiologists, and neurosurgeons.
Any other questions about this?
No.
Okay. And then, is the commission generally supportive of this tack, or?
We're talking about a letter of information.
No, we're talking about actually a
letter of support.
It'll be a letter of support with amendment.
I don't disagree.
Okay. Okay.
Tacit consent.
Tacit consent. I will.
Okay.
Okay. So then that moves us on to the next bill. So Senate Bill 4669 is the Senate version of a bill we talked about a few weeks ago, HB 409. This has to do with electronic prescribing. And mandating electronic prescribing. We had submitted a position paper in opposition to House Bill 409, so I was going to recommend that we submit the same paper for Senate Bill 469.
Yes, this is basically the position that we had taken
Yep.
in our legislative conference, where we basically, I think it was a universal view of the commissioners who were present, that this was an unnecessary intrusion into the doctor-patient relationship, and we've made that very clear. I don't think that there's any reason to change that position at all. We should clearly oppose the legislation and let the state legislature know that.
And then the final bill allows physicians to delegate some duties to a new provider category called Registered Cardiovascular Invasive Specialist, subject to regulation by the Board of Physicians. This bill is related to a work group that the Board of Physicians had conducted, and they have a report on the topic on their website. One component of this bill is that MHCC conduct a review of this type of practitioner and submit a report after they've been practicing for a period of time. So we are recommending a letter of information with respect to the study component of the bill. We're not taking a position with respect to whether these practitioners should exist or not, but we do want to provide the legislature with some information about the data we currently collect with respect to cardiovascular programs, which does not include the data that is asked for in the study. So it would require a different us to set up additional data collection methods.
Commissioners, any comments? Dr. Peters, anything on this? Dr. Pollack?
Okay. Thank you. So then I just wanted to give a preview of the coming weeks. We're about halfway through the session at this point. Next week we will have a longer meeting. We'll have to start at 7:30, so we give you all warning ahead of time. We'll probably have about 6 bills to discuss, mostly related to CON or health facilities in some other way. A list of those is available on your slide. The week after that will be lighter again. From what we can see, at that point we will discuss most of the bills that are moving, and it will just be the opposite houses version. I did want to also give a logistics update. I will be changing the call-in number for the conference call. A couple of you have provided feedback about getting muted and not being able to come off mute, so we're going to use a different system. So I'll provide that information when I send out the appointment next week. And then finally, I did want to let you know that Ben and I have a couple of meetings with members of the legislature tomorrow that will largely be focused on these CON bills. And we did discuss the hospital closure notification bill with Delegate Lasante last week. Any questions about any of that? Okay.
I would, before you
Yes.
leave, well, either you or the director, what kind of reception is the CON legislation getting with members of the legislature, to the best of your knowledge? What's the let me put it this way, what's the temperature feel like there?
My sense.
Now, it's a very subjective thing.
Right. My sense is that we have support for the thing. So some of these bills are very closely aligned with some of our recommendations.
Right.
And I think we have some support from some key leadership for that. I think we'll know more after tomorrow, and we'll have a better sense. Yep. Any other questions? Yes.
And I think at the next call, we'd be discussing the CON bill that we say is like partially in line with the CON report. I think it's 931, Senate Bill 940. Is that like on the agenda for the
so next Friday we will be discussing the ones that we think of as being aligned are there's one that's Pendergrass sponsored and MHA put it forward. That's pretty closely aligned. And then there's another one that's Krebs, Delegate Krebs sponsored, related to the change in bed capacity. So that is also fairly closely aligned.
All right. Thank you for reading all of the bills. I understand there was a record amount of legislation introduced.
I have not read all of the bills. I've read the ones that are relevant to us. Yes, you're welcome.
Make sure you have a chance to see Mr. Smith Goes to Washington.
Oh, I've seen it. It's a great film.
Yes.
Yes.
When you're done reading all the other bills.
Yes.
Okay. Thank you very, very much, Megan. Thank you. Okay. Next item is an overview of the telehealth readiness assessment tool. And Alana Sutherland, Program Director in the Center for Health Information Technology and Innovative Care Delivery, and Sarah Hawk, do I pronounce that properly? Oh, okay, good. Senior Health Informaticist from RTI International, right? Will present on the telehealth readiness assessment tool. The idea behind this is that medical practices can use the tool to assess their level of readiness for offering telehealth services, identify areas that need some improvement, make priorities, establish, get help to make sure that they're doing well by their patients and the caregivers, whether or not they are meeting their organizational readiness targets. So the tool also has supporting guidance for helping practices prepare for telehealth. This is a really exploding area right now, telehealth, and very interested to hear what you have to say about how things are coming with regard to the readiness.
Thank you. I'm pleased to be here to present this draft tool after about a year of gestation. We think it's something that will have value to a lot of small practices in Maryland and most likely many others. So the Maryland Healthcare Commission used lessons learned from its many telehealth grants that have been awarded for the implementation of innovative projects in Maryland. We also had discussions with telehealth leaders in the state, and those advised the initiation of the development of the telehealth readiness assessment tool. So implementation of telehealth services can represent some challenges to practices, and it requires them to shift how they operate and how they provide care in a lot of instances. And this can be because organizational processes are often set up to favor or support face-to-face encounters. So the TRA tool aims to support practices in determining their readiness for implementing or scaling up a telehealth project. And this was an important factor because we wanted the tool to be useful not only for practices that had not yet implemented telehealth, but also for those that were already using telehealth and looking to improve the delivery of their telehealth services for ongoing success of a project. So it will help to inform practices as they look at the providers, the patients, caregivers, as well as their organizational readiness. It will also help them to identify areas for improvement so that they can take steps to increase their level of readiness. So the project began in November of 2017 when we released a funding announcement for the development of the TRA tool. And in January of 2018, Research Triangle International, or RTI, was selected through a competitive process. And some of the key project milestones include the development of question categories, the development of specific questions within each of those categories, as well as a scoring methodology, conducting preliminary field testing of the assessment questionnaire, drafting supporting guidance documents, and then additional field testing and stakeholder reviews of the full TRA tool content. So as the chairman mentioned, Dr. Sarah Hawk is joining us over the phone from North Carolina. She will speak more about the development of the tool and some of the project milestones. And Dr. Haas is a senior health informaticist with RTI, and she oversees their telehealth research portfolio. So I will hand it over to Dr. Haas.
Welcome, Dr. Haas.
Thank you. Thank you so much for having me. And I'm sorry that it didn't work out for me to come to Maryland this time, but through kind of a form of telehealth technology in a way, we're able to meet together today. So the tool is comprised of 5 key domains, and as we just discussed, identification of the domains occurred through a review of peer-reviewed and non-peer-reviewed literature, best practices from the industry, and items that we've seen through change management and other related health IT implementation literature. So really, the domains were cross-cutting, and I'll go through them briefly here. The first domain is core readiness, and core readiness is how much has the practice really thought about telehealth? Are they really ready? Oftentimes, folks might say, oh, it'd be great to have telehealth, but then when thinking about what it really takes, it might be a little more daunting than one might think. And it's all right for any of these if a practice doesn't have a great score right off the bat, because the whole purpose of the tool is to help practices think about and look at different dimensions of these domains and then think about what activities need to occur prior to implementation. The second one is financial considerations. Oftentimes, the telehealth vendors or, people really talk about the promise like, oh, you'll get so much more reimbursement, but you need to temper that with looking at costs, both one-time and ongoing, aspects of sustainability, and there's so many different changes. So, for example, in the 2019 physician fee schedule for Medicare, there have been a number of changes, and of course, states always have different changes in the private and public payer sectors. And then, of course, there are changes that occur with legislation and different policies, both at the state and national level. So it's not expected that physician practices would know all these, but just that they've thought about it and have a plan for the financial consideration. The third domain is operations, and that's really the nitty-gritty of where telehealth can change everything from scheduling through where a visit actually occurs, through billing and coordination. So those are some of the aspects of operations. And of course, the staff, both the provider and the staff that work with him or her, are a key component of telehealth because, as you all know, with any change, be it technological or not, if folks aren't on board and trained and ready to go, then it can be very difficult to have those changes both to start and to kind of ongoing. So staff engagement is key. And then, of course, patient readiness. Telehealth represents a big change in how care is delivered, even if it's often the same. So, there are some things to think about with, who are the patient population? Are they technologically savvy? Do they do a lot of tracking at home? Do they have to travel? So not only, would they be amenable to telehealth, but what are the barriers to access that perhaps telehealth could overcome? So even if they're not technologically savvy, maybe then they don't want to drive from, one side of the state to the other for care. So that's a quick overview of the domains, and I'd be happy to go into more detail at any time. But for now, I think we can go to the next slide. So this was our development approach. As I mentioned, the domains kind of served as our overall framework. And the overall framework then kind of went to the question categories. So what we did is we organized the tool around those domains. And then within each of them, we had subcategories, because otherwise, there would be a number of questions on, say, operations that would be jumbled together. So we had subcategories to organize, based on topical area. And all of these were based on an evidence-based approach. And it was informed not only by the peer-reviewed literature, but other sources as well. And I'll go into that a little bit more on the next slide. So the questions, and then how they were scored, and then the guidance. So that means, after a practice completes the tool, there would be guidance that would kind of pop up. So a little bit more information. You could think of that like fact sheets. So for example, for each one of the key categories and subcategories, there would be references that the practice could refer to. So what does it mean if you need a little bit of help on patient readiness? What can you actually do? Things like that. And then, of course, a set of telehealth resources. Because the guidance, we really made an effort to make it easy to read and relevant for practices. But of course, some folks might need to learn more. So that's where the resources come into play. And as I mentioned, we took an evidence-based approach. RTI has MLS-trained librarians, and we use them to help us identify keywords, also conduct the searches, and that includes peer-reviewed journals, which is what people more traditionally think of, but also kind of like what we were talking about in the presentation with Johns Hopkins. You have to think about how knowledge goes into practice. And so then we looked at sources such as issue briefs, government reports across the country, and conference proceedings, both for industry and for academic conferences. So we looked at a variety of sources and tools that are commonly available. And that's what we used to devise the categories, the questions, and the guidance. And then, of course, once we have the initial set, then we need to test it with folks in the field. And so that's where we had the first round of field testing and stakeholder interviews. So we did that initially, made some changes, and then we had testing again. And I think we'll cover that a little bit more on the next slide. So in terms of field testing, our goal, which it was difficult, but we were able to recruit physician practices, and Angela, who was with MHCC, and Alana were so helpful in helping us with recruitment, because really having those local connections was very helpful. And in terms of field testing, we looked at, did the questions measure what we wanted them to measure? Did the guidance make sense? Was it confusing? Were any questions confusing, or maybe people didn't really understand what we were asking? Or was it relevant? And it's important to note that we tried to get physician practices across the state and across different provider types. So that way we could really get a cross-section of experiences, because otherwise it could be heavily weighted one way or the other. And we also sought to look at practices that were not necessarily affiliated with an academic organization, because resources and IT support and all that are different in a private practice setting versus in the academic setting. And in addition to the physician practices, we also had some stakeholder interviews at both phases. And the stakeholder interviews were helpful because the stakeholders really had a broad perspective. So that way we were able to learn from their experience and knowledge as well, because they were involved in telehealth efforts more broadly. So that summarizes our approach, and then I think I'll turn it back over for next steps.
Thank you. So next steps for the tool include finalizing the tool and submitting it for copyright registration. Once the tool is finalized, we will post it to the MHCC website while we seek a vendor to automate the tool. And the tool, once it's automated, we're aiming for it to be very user-friendly and interactive. So we also plan to develop articles and presentations for distribution and to promote the tool. We'll target local medical associations, symposiums, publications, and newsletters to really try to raise awareness amongst practices about the value of the tool. So that concludes the presentation, and we'd be happy to take any questions.
Okay. Thank you very much. Ladies and gentlemen, do we have any questions? Yes, Commissioner Sargent.
I always have a question. I apologize in advance. So I was looking through the tool, and it looks great. One of the practical aspects of a practice going into this is figuring out which services their customers are going to be most amenable to, so that they dive in with both providing the technology and I've noticed you don't have that in here, and I'm not sure that it would be appropriate to be listing off medical services that they should consider. But are there resources that if I have a PCP practice or a cardio practice or something, where I could go to find out the most likely services I should start with if I want to go into this area.
Sure, yeah, and I'll let Syra jump in as well, but I know that we did definitely consider that in development of the tool, and the reason that we left it out was mainly because we wanted the tool to really be applicable to a large range in terms of the type of practice and their focus. There are resources. There is a sheet at the end of the tool that provides additional links to external resources for information. I would say probably the Maryland Telehealth Alliance might be a good source for that type of information, but I'll let Syra add any if she has some on the top of her head.
Yes, and one thing that we did add was in the core readiness section is that we had a place for providers to look at their patient population. So we wouldn't expect that they would know the answer when completing the tool, but one set of questions that we took them through involved thinking about, are your patients, doing things like monitoring at home all the time and then bringing in pieces of paper? Is your patient population have access issues? So it doesn't necessarily say if you're this type of provider, these are services for you, but it actually has them looking at their own patient population and their own needs and using that as a mechanism to select. And so that would be part of the core readiness. And then there's a little bit of that also in the patient readiness domain. So that's how we address that in a way that would be a little bit more generalizable. So that way we don't have multiple versions running around, but also not so prescriptive.
Director? So, one of the readiness factors is your payer mix and whether those payers are actually participating. How does that come into play?
Yep. So in the financial readiness section, I believe we spoke about the different types of payers and some of what those requirements might be and what you might want to consider there.
Commissioners, any further questions? Thank you very, very much. Thank you. All right, our next item has to do with an overview of psychiatric hospital services. The Commission has regulatory authority over the development of psychiatric hospital services. We do this through the Certificate of Need program. In 2018, the Commission developed recommendations to the General Assembly on reforms to streamline the Certificate of Need process and to align the program with the total cost of care. The modernization of COMAR 102407, the state plan chapter for psychiatric hospital service, was referenced as a chapter in particular need of update. The Commission today is releasing a white paper that will serve as a starting point for updating that regulatory chapter. Paul Parker and Mario Ramsey will present the overview in the white paper on psychiatric hospital services. I just would like to mention before we begin that Eileen Fleck also had a nice major role in developing the white paper. Okay, so Paul.
Thank you, Chairman Moffett, members of the Commission. And you're quite right. I am here serving as a spokesperson for Eileen, who isn't with us today. But the major work on this white paper was done by Eileen and Mario Ramsey, to my right here, who's a program manager in our acute care policy and planning division. So what we are attempting here is not to answer all the questions. Certainly, I think it's fair to say we're in some ways just scratching the surface, but we were trying to put together a compendium of kind of the key data that would serve as kind of a baseline for starting a discussion with a work group that we are going to be convening in the next few weeks to start the task of updating our psychiatric hospital services chapter of the state health plan.
All right, so good evening, everyone. I'm just going to give a brief overview of some hospital bed capacity trends relating to acute psychiatric care. So from 2011 to 2018, we are looking at a decline of actually just less than 1%. Some of the 507 number on the graph there is supposed to be 607. So some of the numbers that I give you are going to be different than what you see on the screen. But the numbers are correctly presented inside the actual white paper.
So physical bed capacity for private psychiatric hospitals is the number he's referring to.
Yeah. And so when we're looking at physical bed capacity, we're talking about beds that are licensed and available for use, but not necessarily staff beds. So the physical bed capacity, there was a change of less than 1%. So the physical bed capacity for acute psychiatric care remained the same from 2011 to 2018. But we did see a 6.7% decrease in private acute psychiatric beds at private psychiatric hospitals, and a slight increase at general hospitals, and a 12.5% increase at state psychiatric hospitals. So this information is as of June 1st, 2018, but effective August 1st, 2018, we did have a change where Adventist Healthcare Shady Grove Medical Center, there were 117 beds from an Adventist behavioral health care facility that was on their campus that were rolled into the medical center. For purposes of this information, we have presented it as it was on June 1st, 2018, simply because without getting the new survey data on what beds were staffed and other bed capacity information, it would be kind of hard to siphon out what those changes mean. But going forward, June 1st, 2019, you should see an increase in the psychiatric care beds at general acute care hospitals and a decrease in private facilities. You have a question? I'm talking about right now. I'm talking about licensed beds.
We could just to make sure I understand. Licensed beds are the licensed right to have a bed, and a staff bed is a bed that's there ready for somebody.
Staff, yes, where there's someone staff to actually tend to the patient who would be in that bed.
In general hospitals, where most of our acute psych beds are located, you actually can't have a difference between licensed beds and actual physical bed capacity. In the other two settings, our state hospitals and our private psychiatric hospitals, we should actually be consistent between what is actually there in terms of physical capacity and licensed bed capacity. I won't guarantee that that's absolutely true at every facility, but it should be pretty close.
All right, so moving on to staffing of acute psychiatric bed capacity. Again, staffed acute psychiatric beds are beds where there is someone who's actually there to tend to the patient who is physically in that bed. So you see here we have overall increase of 4.1% from the time period of 2011 to 2018, with the highest increase being in state psychiatric hospitals with a 12.4% increase. So the 4.1% increase overall during the same time period, we had a population increase of roughly 4.5%. So just to give a perspective of the increase. And then trends in acute psychiatric bed utilization. So the average daily count is the average number of patients per day in a facility. And so we've seen for general hospitals that number declined by 8.6%, but increasing by 9% in state psychiatric hospitals. And so overall, there was a slight decline during that time period. And for average daily census, we're looking at data on a calendar year basis. We're not looking at that June 1st date.
So the next slide, this is showing what's going on with average length of stay in general hospitals and private psychiatric hospitals with respect to the last 9 years or the 9 years between 2008 and 2017. As you can see, our average length of stay is increasing pretty substantially over a full day over that time period. Next few slides, we're going to be looking at the population use of acute psychiatric hospital beds. And these first two charts are really just looking at, again, the biggest sector, which is the general hospital setting for psychiatric care. And when we look at national discharge rates, we see a slope that's going up, an increasing trend. And for 2015, using the HICCUP data, which is a data source that the federal government has assembled that really provides you with a range of state hospital discharge databases. We're looking at a general hospital psychiatric use rate of 451 discharges per 100,000 population as a national estimate. And then in our next slide, we're looking at Maryland, again, just at the biggest sector, the general hospitals. And our trend is better, but this certainly suggests that Maryland may have a relatively high use rate of psychiatric hospitalization compared to the rest of the country. And this is looking at both Maryland and DC hospitals because we have access to those two discharge databases. In this next slide, and apologize for it being pretty hard to read, but here we're adding another element. We're adding both. We're looking at both general hospitals and private psychiatric hospitals here. We don't have the state psychiatric hospitals in these use rate tables, but we're accounting for about 75% of Maryland psychiatric hospitalizations. And here, the rate is calculated differently. This is a rate per 1,000, but as you can see, when we add those private psychiatric hospitals, we're getting up to about 730 discharges per 100,000 for Maryland. Again, we don't see the use rate increasing. It's been moderating since 2012. So just in summarizing these three population use rate slides that we've looked at here, I don't think we know really how bad the comparative picture might be, and I probably even shouldn't use the word bad necessarily, but certainly there are indications from the data that we've assembled so far, and we're going to continue to work on trying to get better apples to apples comparisons here. But certainly the indications are that Maryland may have a relatively high use rate for psychiatric hospitalization, and that certainly has implications in terms of, are we doing the best job we can at creating an effective continuum of care where we're moving as much treatment into outpatient programming as we can? Are we managing cases here effectively, because a lot of these cases do require long-term management? Are we managing them effectively so that we don't see these patients continually going back and being hospitalized during the course of their treatment? So we see this question as obviously a central one that we want to look at with the work group. Trend in emergency department use. Certainly, when you read the white paper, you'll see information there that's been put together by the Maryland Hospital Association, suggesting that we do have a problem in terms of moving psychiatric patients through emergency departments. There's boarding going on. There's very long lengths of stay. Anecdotally, I hear a lot from hospital administrators about the fact that it's getting tougher to get these patients transferred quickly when they need hospitalization. What we see here is that we've had a healthy, upward trend in ED visits by persons who have a primary psychiatric diagnosis. This is clearly not representative of overall demand for ED treatment over this period, because what we've seen since 2010, 2011 is some real moderation in visit volume overall at Maryland EDs. But we are continuing to see, pretty strong growth in visit volume for this particular type of patient. But a 15% decline over this period in how many of these visits actually convert into hospital admissions, declining from near 25,000 in 2008 to just over 21,000 in 2017, which on face should be a good thing. So just to highlight some of the questions that emerge here, and again, I think I characterized the white paper as, in some ways, just kind of scratching the surface on this area. And this slide presentation, we've only focused on really about a third of the white paper in terms of looking at the key kind of capacity and use trends. But we definitely need to confront the question of how appropriate is Maryland's use of psychiatric hospital facilities. Again, certainly the indications of the data we've looked at is that Maryland has a relatively high hospitalization rate when compared to the rest of the country. And that obviously includes the population discharge rate and then also the increasing trend in length of stay that we see in Maryland. And then, comes central to the update and modernization of our state health plan. We want to look at how do we have a set of policies and standards in that plan that best address the growth that we see in demand for child and adolescent psychiatric hospitalization. That's where the growth is occurring, and it's not in adult psychiatric hospitalization. We want to try to understand the overcrowding of hospital EDs and the contribution of the psychiatric patients to that problem. And are there things that we can be looking for in capital projects that will address that problem and that we can either favor, or if we think they're missing the mark, have a set of regulatory policies that maybe point the industry in the right direction. And then, if population use is unreasonably high, I think we need to challenge applicants who may want to build more bed capacity in this state to really show us that, at least in their region or in their service area, they're developing efficient and effective channels for patients to use outpatient care when that's appropriate, and more effectively manage patient care over the long term to try to reduce hospitalization. So the white paper, we did post it on Monday. This is just giving you a flavor of what the sections of the white paper address, and we really focused here just on the trends in supply and use, but we also address the issues of access, other behavioral health services other than hospitals. And then there's a lot in this white paper, because it is intended to be primarily a kickoff for a work group on what is our current state health plan for psychiatric services, hospital services say, what aspects of that chapter are probably current, maybe need to continue to be included with some updating. What are parts of that chapter that are obsolete and we can discard of? And what are some areas that we need to think about including in a new chapter that we really don't touch on? So I've got this incredibly long web address here. If someone wants to to find this on our website. There's copies of the white paper that we made for the back table here today. But essentially, as a quick guide, if you go to healthcare community on our homepage, which is one of the two big groupings there, and then go to healthcare facility services and then state health plan, that's where you'll find it. The state health plan page has a section on areas that we're working on, development and updated state health plan chapters. And so as that process of updating a plan and working with work groups goes on, we populate that particular location with all of the materials that are used in the work group meetings, and the white paper is there. I'd be happy to answer any questions you have.
Any questions? Yes, Candace?
Was the diagnosis required for admission looked at all for these psychiatric hospitals?
Well, when we used primary psychiatric diagnosis, a lot of these tables, what we used is what's called a major diagnostic category, which is 19, which is kind of a comprehensive assembly of those diagnoses.
Okay.
Commissioner Sargent? That's a good question, because to me, when you look at these sorts of reports, which was very interesting, thank you for putting it together, is you can see indications of where you would want to look further, but looking at the number of discharges from the hospitals, maybe higher or lower utilization, it leads to the next question of, is it inappropriately high, or do we just have more people that need that level of care, or are we using that level of care differently from other jurisdictions, which leads you into a much more detailed view of the medicine as opposed to the high level numbers. So obviously we don't expect that from the sort of report, but it raises questions that need follow up at a much lower level.
Absolutely.
Commissioner Pollack?
So, comment and then a question. So the comment is that yeah, I get it, where our utilization rates are high, but we still have an ED problem with patients waiting in emergency departments. And the need to solve that problem is compelling. And the degree to which that is compelling, in my view, outweighs from a public health standpoint the concern about having too many beds. If we can make more beds and solve that problem, that's a huge safety issue that we have right now. We've got patients sitting in emergency departments with psychiatric diagnoses being cared for long periods of time. I'm talking about sometimes in excess of 30 days. When I say sometimes, I don't mean like occasionally, I mean like regularly. People sitting in emergency departments in excess of 30 days not getting the care that they need because the psychiatrists aren't practicing there. And that's a problem, but what's really a problem is the ambulance wait times that result from it. So you wind up with hospital beds filled with psych patients. You have medic units coming into hospital emergency departments with acute emergencies, and they're waiting for a bed because several beds are locked up with psych patients. And when they wait for a bed to unload, that means that they're sitting there waiting to unload, and they're not back out on the street. And it's the cumulative effect is the increase in the 911 response time. So the danger that this problem represents in emergency departments is compelling, and I think that level of urgency needs to be attached to the solution. The question is, I understand a couple of years ago, maybe around that time, there was a change in the way that forensic beds were managed. In other words, psychiatric beds that were reserved for people who were incarcerated or otherwise in one of our state hospital systems. And the feeling amongst some of the providers is that had a major impact on access to beds, particularly the state beds. Any thought about that? Was there any look at that in this report?
So the capacity that you have at the state hospitals, some of it's chronic long-term care beds. We're really focused on acute care here. And the evidence we've seen indicates that almost all of that acute care bed capacity in state hospitals that's being made available for that type of short stay patient is forensic.
So for a non-forensic patient, those beds are basically not available.
There does not seem to be access to that.
That's consistent with what I'm hearing.
And that's changed. It didn't used to be that way.
I think that's a piece of what we're seeing in terms of hospital wait time.
Mm-hmm. And think most of you understand this, but at the end of the day, we're talking about CON regulation. So we categorically regulate bed capacity at hospitals. We don't categorically regulate ED treatment capacity. We often see capital investment in emergency department facilities because they get swept into projects that require CON regulation for other purposes. And in the last decade, we built a lot of additional hospital ED treatment space. And that was a very logical response at the time, it seems like, because we had just incredible growth in ED visit volume. So we now have more ED treatment capacity, a lot more than we used to have in hospitals. As I said, we've actually seen moderation in overall visit volume, somewhat different picture in the psychiatric side. But we also have these changes in the hospital charge regulation, I think, that are contributing to hospitals really taking more time to make decisions about whether to admit patients to the hospital, whether to admit them to observation. So it's a little frustrating when I look at, the additional treatment space that's now out there and an actual moderation in visit volume, but we see diversions going up, and anecdotally we still hear these horrible stories about how long people are waiting. We know that Maryland's statistics on ED wait times in general are really bad, among the highest in the country. So it's a complicated issue, and it's not one that we necessarily directly influence through CON regulation and the standards that we set, because again, we don't categorically regulate ED treatment capacity, but that's not necessarily the issue. I think it's not a simple issue of just either bed capacity or ED treatment space capacity.
Beyond just the CON piece of it, I mean, I think we have an obligation at the end to come up with to be a part of the solution to the problem, highlight the problems, and then come up with potential solutions even if they're not.
And we'll certainly try to do that as part of the state health plan update process.
Yes, one quick one.
Right.
In terms of as we're starting this process, and this is certainly a great start, do we have a feel for how this fits into the framework of total cost of care?
It's something that we clearly are going to have to address in all of our state health plan chapter updates. But I'd be reluctant to actually talk about any specifics right now.
What percentage of this is Medicare? Is Medicare fee for service?
I don't have that offhand. I can get that to you.
I guess it's rather small.
Not real big. Not real big.
This issue of the long wait times for people who are seriously ill, at some point this is going to hit the media. I mean, I haven't seen anything yet, but I think it's incumbent upon us to make sure we get out ahead of this. I mean, we don't want to. We talked about this previously, I think, in other contexts. We don't want to have a situation where the Baltimore Sun or the Washington Post do a story and we're not on top of it and we're sort of caught flat-footed responding to this. I think we got a problem. We got to figure out exactly how to deal with it. I don't know how to deal with it. And you're probably right. It doesn't necessarily have anything to do with the CON regulation. But certainly, the broad responsibility, the broad statutory responsibility of the commission includes quality of care. This is a serious quality issue. People waiting. Pardon?
I can see it as part
of
the
consumer portfolio. It's on our watch. We got to figure out how to deal with this. Teresa Lee will probably have some ideas, but we're going to have to focus on this.
I mean, do we even have the base data of how bad the problem is right now? Okay.
But is that the ED general? We know it's not good. Yeah, and that's, yeah. Yeah, that's good, because I just think that, once again, it's better if we shine a light on our own problem, rather than have somebody else do it. And, it's obvious, but we've got to think about this.
the data sets that we have to look at how hospitals are used, they don't let us really drill down into, okay, what exactly is happening at the CD, how many patients are spending, inordinate amounts of time in the ED, and what types of patients are those. Those just really aren't in those databases. But that's one of the things we're going to talk to this work group. Can we actually get some better insight on the specific?
Or as an organization, I mean, there's other things we do. Do we want to do a survey every 2 years of wait times and draw a sample and talk about what kind versus, severity, and to a certain degree, make sure we have the proper authorization, but take it out of the hands of the ED department, who are clearly quite busy. And also any question that they're sort of, lowballing on how long they're at their particular facility. So, I mean, there's moves we can make here, and I think Bob has a good point.
Right. Commissioner Pollack, you got another observation?
Well, I just say one of our sister commissions at MIMS that we could, they have data on medicated wait time, which is a very important surrogate of overall wait time that we need to understand. And I think talking to them about collecting, sharing it, and allowing us to report it would be very valuable.
That sounds like a great idea. Commissioner Peters.
But I also think that this goes again, we need to know the diagnosis of why people are coming into the ED, because are they flooding the ED because they are detoxing off of drugs? Are they flooding the ED because we have a homelessness problem? That goes into why are these people in the ED, and then we can try to solve the problem. But just to say that there are numbers and we don't know even where to start to solve the problem then. So I don't know how we would get access to the.
I mean, you know better than I do. We've had a problem with a lot of poor, helpless people who are very, very mentally ill, who are there out on the streets because of a move toward deinstitutionalization of mentally ill many years ago. Mm-hmm. And in some cities, it's really starting to come to the fore. I mean, without going into unnecessary detail, I see it every day outside of Union Station going to work. I mean, these people are really in trouble, and I don't know what they do. I mean, I don't know if they go to the emergency room or not. I mean, I think frankly, some of them, are really beyond help in some cases. It's really bad. Okay. That sounds like a very, very worthwhile thing to do on behalf of the public.
Paul, what are the plans for the work group?
Well, we'll be putting out invitations and asking for nominations over the next couple of weeks.
And the duration?
In the last few years, we've been trying to limit work group meetings for state health plan updates to like three or four meetings. We can possibly wrap it up, but it really depends on,
If this is an issue that is particularly important to a commissioner, as Commissioner O'Grady served on the organ transplant state health plan modernization effort, please let Paul know. That would be, we'd welcome commissioner participation at an early stage. If we don't have commissioner participation, we likely would do something we did with the nursing home regulation, establish a group that we would that group of commissioners informed at a more detailed level on what's happening. So I'm open to either model.
Any further questions? Any further questions? Thank you very, very much, gentlemen. Thank you. All right. Ben, would you like to share the upcoming initiative for next month?
We do have a few things that I want. I'm not going to be exhaustive today, but we hope to have our contested CON review on the docket in March. That's one that been challenging, but we think we can move that forward. We also will be bringing forward potentially one or more other CON applications. We'll also have David Sharp's team provide information on our work in developing templates, much as we do for telehealth, for establishing patient family advisory councils that are now key to many of the physician-based initiatives in the state, and most significantly the Maryland primary care model, that their practices are required to have patient family advisory councils as part of that model. We think we can help resolve some of the confusion by developing some templates for them to work from. We'll also be bringing to you forward recommendations, I think, on the Maryland Primary Care Advisory Council. That's a group that the Commission is responsible for convening, that will provide input to the department on the evolution of the Maryland Primary Care Program. It will be a fairly large group. The Commission selects the council. The Secretary picks the chair. Naturally, I think the Secretary will be somewhat involved in the broader membership, so that there's membership, including someone that he thinks is appropriate for chairing that group. I think right now his thinking is co-chairs, one a primary care physician and one another, but there'll be more on that as the meeting approaches. We'll also have some legislative updates and have a good sense of where things are going with our 3 CON bills, as well as a couple others that we're monitoring. In passing, Megan mentioned a meeting we had with Delegate Lasanti last year. You may recall that she had a very ambitious bill that we actually encouraged her to withdraw. She asked us for some assistance this year in something that we would find acceptable. We'll be circulating, if we move forward with that, we would circulate that idea forward. My thinking is that perhaps some requirements that apply to jurisdictions with 3 hospitals or less could be applied statewide with regard to public information hearings, but I wouldn't go much beyond that. I think, as you all know, our authority here is limited, but I think we are increasingly seeing with certain, without regard to whether it was necessary, certainly a very clumsy situation at Franklin Square where people were dismissed and the pediatric ED was closed, without significant notice, was something that could be done better, and perhaps in a limited way we could provide something that would be helpful both to hospitals and to the public, so that people are aware, better aware of transitions that are occurring. So we haven't committed anything, but we're looking at that and we'll circulate that before we pass it around more widely.
Are there any further items? Nothing? Do I hear a motion to adjourn? Second? Second. All those in favor? Opposed? Good. Have a great day, ladies and gentlemen.